Madam Dr. Kasturiratna and Dr. Amal Tilakaratna for re-initiating the regional programs and inviting us to speak on this program. Today, actually, it's nice to be back at Matale. I feel really homely. I can see many familiar faces. I started my career here. I came here as a post-intern medical officer in MO Radiology, and we did the first clinical session here with Dr. Manil Piris when we were the post-intern medical officer. Right. So my task today is to talk on this topic, an overview on inflammatory arthritis for primary care physicians. It is actually a vast area. This is entire rheumatology, inflammatory arthritis. So what I thought is I will discuss the concepts of pathophysiology and the principles of management, and then you can understand how it differs from degenerative conditions and why identification and treatment is needed soon. Right. As I said, inflammatory arthritis contains a lot of conditions. You have a pointer? Right. So why it is called inflammatory arthritis? Arthritis itself says inflammation of a joint. We say inflammatory arthritis because of a reason. You can see the normal joint here, and you have the bone, articular cartilage, synovial membrane, which is the most important part in inflammatory arthritis. In degenerative conditions also, we call it osteoarthritis. There is also inflammation, but secondary to the structural damage. But in inflammatory arthritis, here I have taken rheumatoid arthritis as an example. In inflammatory arthritis, the inflammation is inherent. I mean, there's no structural damage. Most of the time, it occurs as secondary to abnormal function in the immune system, or in other words, due to autoimmunity. This is what we do in rheumatology. This is what rheumatologists do in rheumatology clinic every day. We pick inflammatory conditions or inflammatory arthritis out of non-inflammatory conditions because we can completely change the natural history of the disease by treating them. As I said, it is actually almost entire rheumatology. So why we should pick inflammatory arthritis out of non-inflammatory conditions? Because it is progressive. Of course, non-inflammatory conditions are also progressive, but this is rapidly progressive. Within 6 months, inflammatory arthritis patient can be chair-bound, whereas in degenerative conditions, it progresses over years and decades. And it is deforming. Of course, degenerative conditions are also deforming, but again, as I said, it's slow, and almost in inflammatory conditions, the deformities are irreversible once it happened, almost irreversible, and inevitably leading to disabilities. These are real life examples. You can see a lady with rheumatoid arthritis, how deforming the disease is, how debilitated she can be. This is the X-ray appearance, and this is a young boy who is just 18 years of age, who defaulted only for 6 months, who had spondyloarthritis with hip joint involvement, who came on a trolley. You can see he cannot move his hips at all. So this inflammatory disease can be this debilitating, this progressive. That's why we have to pick it up. not only joints are affected. So we know how joints can be affected. There are systemic syndromes, inflammatory arthritis, compared to degenerative conditions. They can have extra-articular manifestations. They vary according to the type of the disease. And you have inflammation generalized. It increases atherogenicity, increased risk of myocardial infarctions, increased risk of strokes. In some trials, in some studies say the risk of MI and risk of strokes is as same as in diabetes mellitus. In rheumatoid arthritis, and there's increased risk of malignancy and increased mortality. So that's why we have to pick inflammatory arthritis. And not only it is debilitating and progressive, not only it affects the system, it is common as well. I mean, when we collect everything together, spondyloarthritis, rheumatoid arthritis, all type of inflammatory arthritis, it is more than 3% of the population is affected. So these are the types of inflammatory arthritis. I know slide is slightly congested, but everything we know, rheumatoid arthritis we know, spondyloarthritis where your axial skeleton is mostly affected. In under spondyloarthritis, you have several categories: radiographic axial spar and non-radiographic axial spar. This radiographic axial spar is the ankylosing spondylitis, and peripheral spondyloarthritis, psoriatic arthritis, reactive arthritis, inflammatory bowel disease related arthritis, juvenile spondyloarthritis, crystal arthropathies, autoimmune diseases, and infection related arthritis. And now we have a new entity called early arthritis. Right. Earlier, those days when we were medical students, these were the classifications we had. Those days, we diagnosed diseases actually when all the damage has, after all the damage has happened. This is 1987 ACR classification criteria. You can see the criteria. There's no place for inflammatory markers. And once erosions have happened, only we were able to diagnose and start treatment for rheumatoid arthritis. This is modified New York classification criteria for spondyloarthritis. Again, you have to have radiographic evidence to confirm that it is spondyloarthritis or rheumatoid arthritis in those days. So the rheumatology changed significantly over the last couple of decades. We realized that there's no point of diagnosing the disease once the damage has already happened. Therefore, we have to, not only we have to pick them, we have to pick them at the correct time, early, before irreversible changes happen. So these are the, sorry about the quality of these things. So we have the classification criteria to classify rheumatoid arthritis, and there are many classifications to diagnose spondyloarthritis. If you're in doubt, you can use these classification criteria and see if your patient is telling with them, you can diagnose inflammatory arthritis. But however, I must say, these are just classification criteria. Diagnosis is not made by the classification criteria. So yeah, as I said, during last couple of decades, we realized that we have to detect them early. Why early? If we take, when I say inflammatory arthritis, I almost always refer to rheumatoid arthritis because it is the most common and most debilitating and erosive arthritis. So we have to pick them early because 70% of these are evidences. 70% of patients with recent onset RA develop bone erosions within the first 3 years. And importantly, within 3 months of disease onset, 25% of patients already have erosions evident on X-ray examination. So you can see how quickly the disease can damage joints. The presence of early radiographic erosions predict the future progression of joint damage. And then we realize there is a window of opportunity. Earlier, when we diagnosed inflammatory arthritis, we thought, oh, now I have this disease, I have to be on medications for lifelong. it changed. So the researchers and the rheumatologists realized that there is a window of opportunity in which if we start the treatment, we will be able to completely take off medicines at one point. So drug-free remission is real. So සිංහලෙන් කියනවා නික්තාවට හොඳ කරන්න පුළුවන්ද කියලා ලෙඩ්ඩු අහන්නේ. So that is possible. So you have to pick them early, and we must use the window of opportunity. We must treat the disease modifying agents early. Right. So as I said before, so all the inflammatory arthritis are, when even if they clinically become evident in later stages of life, they are considered as a disease continuum. I mean, when you're born, you have the gene, you're going to get this disease. When the environmental triggers are met, you will develop the disease. So you have the disease actually subclinically inside you. So you seem healthy, but you have the tendency to develop inflammatory arthritis in future. Then you develop arthralgia, and with this, sometimes you develop the autoimmunity, and then you develop early arthritis. At this point, you cannot classify it, but you have early arthritis. So our aim is to treat them pick them at these stages and treat them and reverse the progression. So that's why inflammatory arthritis is important. So I said there are several classification criteria, but you don't have to worry. I mean, it is so fancy to know all classification criteria, to use all classification criteria, but diagnosis is clinical. We all can diagnose inflammatory arthritis. We don't have to have classification criteria. We are equipped with everything to diagnose rheumatoid inflammatory arthritis. So classifications are used in the researchers mainly in a target population, but we don't see a target population, we see the general population. So we diagnose the disease by applying our clinical sense. But in doubtful cases, ambiguous cases, classification criteria can be helpful to diagnose the disease. Right. So all you have to see whether this patient is having features of inflammation in the joint. So this is good old things that we learned in pathology. So heat, redness, swelling, pain, and loss of function. Whether these things are there in the joint. Okay, warmth can be there. Redness, of course, will be not there, but you can sometimes get dusky discoloration over the skin. Redness will be there only in crystal arthropathies and septic arthritis usually, and there will be swelling, pain, and reduced range of motion. Right. So again, I always want to show you how you differ it from the degenerative or damaged joint. So usually, you learn in medical school, inflammatory pain is more in the morning. It is associated with early morning stiffness, more than 30 minutes. So usually in the affected joint, there will be pain and stiffness more in the morning, more than 30 minutes, and there will be warm-up. And there will be stress pain. Sometimes at the beginning, you will not have reduced range of motion, but at the extremes of range, you will get pain in earlier synovitis. And capsular soft tissue swelling will be there, effusion will be there. So this is how you diagnose arthritis or synovitis in a joint. So it is not difficult. Right, then you know that this joint is inflamed. Then how do you know whether it is rheumatoid arthritis, spondyloarthritis, crystal arthritis, or some other connective tissue diseases? We diagnose this by recognizing the pattern. Rheumatological diseases are mostly diagnosed by recognizing the pattern of joint involvement. There are typical patterns. And mind you, sometimes I might overgeneralize things in my lecture for you to understand it easily because I have very limited time. So there are patterns which I will discuss. And once you have, so we identify the pattern. If one joint is affected, it is a monoarthritis. And if it is a large joint, it's large joint monoarthritis. If few joints are affected, we see whether if it is less than 4 joints, it's oligoarthritis. If whether it is large joint only or whether small joints and large joints are combinedly affected, whether it's symmetrically affected, whether it's asymmetrically affected. What are the extraarticular manifestations? Whether eye is affected, is it episcleritis or uveitis? Depending on these things, we diagnose the diseases. And sometimes we might have several differential diagnoses according to the pattern. Then we do the detailed investigation to come to a final diagnosis or differential diagnosis. So this is, as I said, this is overgeneralized. So what is the pattern of rheumatoid arthritis? We know this. It is usually common in females, bilateral. Onset is common between 30 to 50 years of age. Bilateral symmetrical arthritis involving small joints of the head. Usually early morning stiffness lasting more than 30 minutes. So yeah, so you know how to identify inflamed joints. Now you know the pattern of rheumatoid arthritis. You must ask the history carefully because we have seen many patients referred to surgeons thinking that it's carpal tunnel syndrome. As I said, once that crucial period of 3 months is gone, her life could be entirely different, right? If we started DMARDs at the earlier first 3 months, she could be someone who can live without medications in the rest of life. So that's why it is important to pick them up. And spondyloarthritis. So rheumatoid arthritis involves the appendicular joint system, the peripheral joints. In spondyloarthritis, as name denotes, it affects your spine, spondylitis. And common in males, it differs according to the variety, but usually compared to rheumatoid arthritis, it's common in males. Inflammatory backache. So again, backache is inflammatory. It's more in the morning. Patient will come and tell you, I have backache, which is more when I get up from the bed, and when I do activities, pain goes away, and it will be there more than 30 minutes. So inflammatory backache, buttock pain indicating sacroiliitis, large joint oligoarthritis, mainly in lower limbs, dactylitis and other systemic features. You know, psoriasis, if it is psoriatic arthritis, patient must be having psoriasis or any family history, first degree relative with psoriasis, enthesitis, tendinitis, plantar fasciitis, and inflammatory bowel disease. So there will be other associated systemic features, uveitis, and connective tissue diseases, of course. When there is arthritis, you know how to diagnose SLE. There will be Raynaud's skin rashes, usually young females. There will be vasculitis, oral ulcers, other systemic involvement. And crystal-induced arthritis, it's monoarthritis, episodic, abrupt onset, very red, hot, angry-looking joint. So septic arthritis is a differential diagnosis. So these are examples of the common patterns. So it is very easy to diagnose, I mean, when you know the pattern. Right. So again, picture, how many minutes more? Right. Okay. Yeah, right. So again, another diagram to show. Now this is chronic inflammatory oligoarthritis. You can see one side wrist, knee, and ankle. So it's large joint, oligoarthritis, asymmetrically involved. And there is this, you cannot see, I think, the whole big toe is affected. It's dactylitis. So this is spondyloarthritis. True that there is no spinal involvement as such at this moment, but still, these diseases are evolving. At the presentation, patient might not have all the features, so they will develop these things later, but you can confidently start them on treatment because the pattern is such that it belongs to spondyloarthritis variety. So this is rheumatoid, chronic inflammatory polyarthritis, symmetrical. So this side MCP, this side MCP, bilateral knees, and MTPs, right? So it's true there are asymmetrical involvement as well, but you know, there is significant symmetry in the other joints. So small joint involvement. This is typical presentation of rheumatoid arthritis. So diagnosis is easy. Right. So then we thought, are you waiting until the pattern is completed? Are we still late? Right. So yes. So as I said, there is pre-RA or pre-inflammatory arthritic phase. Still, the damage is happening inside the body. So we are not going to wait until patient develops the classical pattern. So that's why this undifferentiated early arthritis came into picture. So if one person comes with one joint involvement, if we clinically assess, and if we feel that this is going to be a persistent arthritis, still we should start them on disease modifying agents. So there are ways to assess that. Yeah. So in early undifferentiated arthritis, what we do is, even if pattern is not there, we predict the patients who will have persistent and erosive inflammatory arthritis in future. So again, I don't know if it is very clear. This is EULA algorithm. EULA is European League Against Rheumatism. And you can see they come with early arthritis, swollen joints with pain and stiffness. And you do the clinical examination and history laboratory testing. And if we have definitive arthritis, I mean, even if one joint is affected, if patient has psoriasis, if patient has inflammatory bowel disease, family history of rheumatoid arthritis, then we know the diagnosis. So then you have to go for the definitive treatment. Then if we cannot come to a conclusion, they go as undifferentiated arthritis. Then comes the problem, because we know some arthritis resolves spontaneously within 3 months or 6 months. So if we are doing a crime if we start them on toxic medication for lifelong, because we attribute that arthritis got better because of the treatment we have started. So that's why we have to assess them clinically, and there are features to see whether this is going to be persistent and erosive. Even if inflammatory markers are normal, if they have, sometimes, even if it is one joint, you might see erosions in the X-ray. That itself says this is not going to get better. So this is going to progress. Patient will evolve into something. So that is enough. And positive ACPA in high titers, ACPA is anti-CCP antibodies, or a rheumatoid factor with the presence of inflammation in one joint, and family history and high disease activity. This is very important. I mean, you know, even if you diagnose the disease, they have spectrum of disease. Depending on the functional outcome of the patient, the disease going to progress. So the disease outcome going to be bad. If 2 patients come to you with knee joint involvement, if in same manner, but if one patient comes in a wheelchair and if other patient comes to you walking, the patient comes in a wheelchair is going to have a progressive disease and bad outcome. So functional decline will decide the future progression, right? So all these things should be considered here, even if it is one joint, even if the pattern is not there. So if risk factors are there, then you know this is going to be persistent and erosive. You can start disease modifying agents at that time itself. Yeah, so methotrexate is the wonder drug. So, and if it is contraindicated, other medications, and then you achieve remission within 6 months, and then you can consider continuation of treatment. This is just for the completeness of sake. Actually, this is the ACR EULA classification criteria, new classification criteria. This also helps us to diagnose rheumatoid arthritis early. If you look at this, if more than 10 joints are affected, at least with one small joint. In here, 10 joints are affected, even if rheumatoid factor, ACPA, CRP, ESR, everything is negative. If it was there for more than 6 weeks, it is going to be classified as rheumatoid arthritis. Yeah, so you don't have to have always positive inflammatory markers or positive rheumatoid factor, right? So we are going to detect things early. So definition of joint, here it says joint involvement. What do you mean by joint involvement? Just say no. Any swollen or tender joint, excluding DIPs, because they are affected usually in osteoarthritis, hands and feet, and first NTP, first CMC. I will not go into additional evidence from MRI ultrasound may be used to confirmation of the clinic. Sometimes we are doubtful. We cannot confirm whether it is or not at the early stages. Then you can use the MRI or ultrasound scan to confirm that. Then, what do you mean by a small joint? MCP, PIP, MTP from 2 to 5, thumb IP, wrist. distal phalangeal joints are not considered as small joint in rheumatoid arthritis because they can be affected in other diseases. Large joint, shoulder, elbow, hip, knee, ankles. Wrists are taken as small joints. Definition of more than 10 joints. Yeah, so there are additional joints, temporomandibular, sternoclavicular, acromioclavicular. Sometimes I have had patients with cricoarytenoid joint involvement as well. Right, so that's how you diagnose it. Right, so now we have the clinical diagnosis, then how you're going to investigate. You don't do fancy investigations, just basic investigations, full blood count, inflammatory markers, liver functions and renal functions, because it will be helpful for management of the disease because we are giving continuous medications, and chest X-ray before starting methotrexate and to see whether there's, I told you there are extraarticular manifestations to see them, X-rays of affected joints to see whether there are erosions, and ultrasound, MRI when needed, especially in spondyloarthritis, we might have to do MRI if we are in doubt. I mean, if there's no radiographic evidence in of sacroiliitis in X-ray, and rheumatoid factor, anti-CCP antibodies, and ANA. And please don't do ACPA unnecessarily. It is expensive, and it's not sometimes. I mean, if you are very sure that it is rheumatoid arthritis and patient is a poor laborer, I don't think it is really needed. You can start treatment, and even if rheumatoid factor is negative, I will not do ACPA in a patient who cannot afford that, right? And in HLA-B27, depending on the types of arthritis. Right. So we know we have to pick them early to treat them early. Just commencing treatment is not enough. We have to escalate them as quickly as possible to reach the target. So we are treating to a target. We are not just giving the medication. So what is our target? Target is complete remission always. And when it is not possible with all available medications, we try low disease activity. This is what our target is. And then only you can reach the drug-free remission, not just by starting disease-modifying agent. And frequent monitoring is needed to see if target is achieved and patient is maintained in that particular target. Right, again, I'm sorry about the crowded slide. So these are the medications we have to keep them in that remission. We have conventional synthetic DMARD. We have targeted synthetic DMARD, biological originator, and biosimilar medications, right? So the conventional synthetic DMARDs are methotrexate, leflunomide, sulfasalazine, and hydroxychloroquine. We all know them. Targeted these are like biologics actually. They are oral tablets, JAK inhibitors, tofacitinib. They are available now in Sri Lanka, even in private sector. And biological DMARDs, you know, adalimumab, Cimzia, certolizumab, betanacort, golimumab, TNF blockers. Both are TNF blockers, and we have anti-CD20 rituximab. Usually that is what we use for rheumatoid arthritis, which is for rheumatoid arthritis, which cannot be controlled with conventional synthetic DMARDs. And usually for spondyloarthritis, we use TNF blockers, conventional in Sri Lanka. So that is how, so we pick them, diagnose them, confirm the diagnosis, started them on treatment, and escalate the treatment using these things to reach the target. Right, so that's all I have to say. So take home message is identify inflammatory arthritis because you can change the life of that person, but not by identifying. You must refer. Okay, refer early. Don't delay the referral. Refer early, and drug-free remission is real, and life without disability is real. And this is my favorite picture. I use this for all my presentations. This says if she has all her joints bent maximally in the lower limbs, and her hands are working nicely. She can do this, and I think she's still earning for her living. But look at her face, the contentment she's having. So health is wealth. That is what we all aspire. Thank you.
Thank you, Sarah. Very informative lecture based on very basic facts. So if you have any questions, come to ask us.
Thank you very much for very here the presentation now from the big aspect. Just a small question. We get a lot of patients with earlier we used to talk about Kaplan syndrome and how often do you see that today? I'm not recently seeing any Kaplan like nodules in the lung, but more inflammatory the other institutional tissue types. Have you seen
no, sir, I have not seen. I don't know, Madam Gunen, how any other colleagues of mine have seen. We do see NSIC and UIC, but no, not nodules. No.
I think that must be more because and I think sometimes some patients actually come to us and then get diagnosed with rheumatoid arthritis. So, thank you.
Thank you.
One question. Yes, one thing, what is the place of rheumatoid factor in the rheumatoid arthritis? Because we do see very pain sometimes might not be and
yes, it is like this, Dr. Trishari. First, we have to have clinically evident arthritis because rheumatoid factor is present in the normal population, even in height eaters, up to 10 to 20% of the population. Therefore, that's why we increase the usually cutoff to 64 as well. But you have to have clinically evident synovitis to use rheumatoid factor because otherwise, if patient has degenerative condition, I mean, if they have osteoarthritis, and they can still have positive rheumatoid factor, which has no place. And rheumatoid factor become positive usually 6 months to 1 year before the onset of clinically evident disease. If a young patient comes with some aches and pains and have very high titers of rheumatoid factor like 256, then you should monitor that patient because she might develop rheumatoid arthritis in future. But ACPA, when you consider ACPA develops early, sometimes 10 years before the onset of clinical evidence synovitis. Therefore, if somebody has ACPA, I think this patient should be monitored because it has more higher specificity than rheumatoid factor, above 90% of specificity. So if somebody has clinical synovitis, you have to do rheumatoid factor. And if you are doubtful also, again, you have to do rheumatoid factor. I mean, if you're not sure whether it is inflammatory or not, because we have to pick inflammatory arthritis and treat them. If you're in doubt, and I would do see a rheumatoid factor, and if they are in high titers, I will give a trial of treatment and see.
In the absence of any patients, it's appreciated for her excellent presentation. We are very happy and proud as a post-intern in Matale. You have gone for a long way and all of you are enjoying. So, thank you. Let's move on to the next lecture. Our next speaker is Asanka Nobel. She's not new person to this state. She's currently attached to DGH Matale. She's going to talk on updates on management of knee osteoarthritis. Over to you,
Push the green one.
Thank you, Dr. Indika. Good morning, everyone. It's very nice to be back in Matale. I'd like to thank the Matale Clinical Society and our college for giving me this opportunity to be back here in this hospital. So today my topic is an update on management of knee osteoarthritis. So before we go to the management, it's just to see what osteoarthritis is. This is the definition given by the American College of Rheumatologists in 1986. So it is a heterogeneous group of conditions which lead to joint symptoms and signs associated with defective integrity of articular cartilage. And also there are changes in the underlying bone and the joint margins. So why is osteoarthritis? So it is the most common chronic joint disease, and globally about 3.65 million people are affected by knee osteoarthritis, and about 4.8% of all females and 2.8% of all males. And we all know that this is mainly a disease of advanced age. So if we consider the age group from 50 to 69, about 14% of all females and 10% of all males suffer from this disease. So we can see it is very common. So before we move on to the management, it's good to have an idea of the pathogenesis. So earlier we used to think that it is mainly a wear and tear disease, but it is not so. So what happens here is there is this abnormal biomechanics which lead to production of pro-inflammatory factors and proteases. So because of these pro-inflammatory factors and proteases, there are changes happening in the articular cartilage, the subchondral bone, and the synovium, and also in the tissues surrounding the joints. So the articular cartilage undergoes some changes, and there is loss of matrix. And the subchondral bone, there is sclerosis, and then there are osteophyte formation that is mainly to deal with the abnormal biomechanics. And then the synovium, there is synovitis, and there is synovial hypertrophy. But unlike in the inflammatory arthritis, the synovitis here is mainly mediated by macrophages. Whereas in the inflammatory arthritis, the mainly involved white cells, leukocytes, and if you get the synovial fluid, you can see a higher number of more than 2,000 white cell counts. But in osteoarthritis, it is mainly macrophage driven. And then there are changes in the joint capsule, because the capsule becomes thickened, and the ligaments and the menisci, they also undergo degenerative changes. So you can say it is not merely wear and tear, there is some inflammation as well. So actually the most recent updates in the guidelines for the management comes from the National Institute for Healthcare and Excellence in the UK, and also American College of Rheumatologists have given out new management guidelines in 2019. So I have referred these two when I'm talking about the updates. So mainly there are four aspects that we have to look into. So information and support, that is very important when it comes to osteoarthritis, because osteoarthritis, there is no definitive treatment as such. So the patient should be given a lot of information and support. And non-pharmacological management play an important role. And there is pharmacological management and also surgical management. So we must, when the patient presents to us, we must actually educate them on what is osteoarthritis and how it progresses. Just because some person gets osteoarthritis early, that doesn't mean that the patient is going to progress into a bad and worse arthritis than another. So it depends from person to person. It varies from person to person, but we must educate them that it is a progressive disease and that they can end up with disability. And then we have to educate them on the flares and how to deal with the flares, because osteoarthritis also can have flare-ups where they can get joint effusions and worsen pain. And then we have to educate them on the lifestyle modifications as well. This plays an important role because before getting the symptoms, they can have they might not be able to do the same things that they were doing before the onset of the illness. So they might have to modify certain activities. And exercise also play an important role. So I will come to all these topics later on. So exercise, we must educate them of the importance of exercise and how to carry out exercises and direct them for programmed exercise programs. And there are many treatment options. We have to discuss them with the patients, and then we have to discuss about the, we have to actually get a targeted or tailored treatment for patients. So we have to discuss with them on the treatment modalities. And then we should provide them with access to additional sources of information. So looking at pharmacological management, this should go alongside with non-pharmacological treatment because we cannot manage osteoarthritis alone with medication. So when we talk about medication, we must use the lowest effective doses for the shortest possible period of time. Because osteoarthritis is it's a chronic disease, so the treatment should go on for years. So we must stick to these principles. So we have to use topical treatment before we consider oral treatment because they carry less side effects. Then there are oral treatment as well as intra-articular treatment. So looking at topical treatment, the topical treatment of choice is NSAIDs. It is strongly recommended by both the guidelines. So it is very effective and it is safe. The side effects are very minimal and it provides the patients with quick relief. So topical NSAIDs, but there are no preferred NSAID as such. None of the NSAIDs have shown any efficiency above the others. Topical capsaicin can also be used for pain relief, mainly for knee osteoarthritis. And topical glucosamines, there are some preparations, but there are no convincing evidence to support its use. When looking at oral medications, NSAIDs are the mainstay of management. We should consider oral NSAIDs when topical NSAIDs fail. And but we all know that these carry a lot of side effects. So we have to monitor for the GI side effects, the renal side effects, and the cardiovascular side effects. So here again, we have to use the lowest effective dose for the shortest possible duration. And here again, the type of NSAIDs should depend on the patient's need. None of the NSAIDs had shown any superior efficacy compared with the others. So if the patient has problems with the GORD, then we must select something like a selective COX inhibitor. When we are using the NSAIDs, we must prescribe with proton pump inhibitors because they can carry GI side effects. Paracetamol is another analgesic that we can use, but it is not routinely recommended as monotherapy, that is to use alone. We cannot manage, it's not recommended to manage osteoarthritic pain alone with the paracetamol, but this can be used when NSAIDs are contraindicated in patients. And using long-term paracetamol has not shown any long-term benefit. So this is preferred when there are contraindications to NSAIDs. We can use opioids, but it is also not routinely recommended. We can use weak opioids like codeine or tramadol, but they are only in special circumstances. When patients are in severe pain for a short duration, we can use, but that is if there are contraindications for NSAIDs. Here also, we must give the lowest possible for the shortest period, because long-term use of opioids is associated with dependence and less pain relief. And duloxetine, it can be used as a monotherapy or in combination with NSAIDs. So it acts as a pain modifier. But this is also is not suitable for everybody because it's not easily well tolerated by patients. They will have a lot of side effects like drowsiness, sleepiness, dizziness, like side effects, and maybe dry mouth. So this can be used in certain conditions for patients as a pain modifier. So glucosamines is another medication that is currently widely used. But the problem with glucosamines is there are no clear unbiased evidence for glucosamines. But even though it's not recommended in the guidelines, in both guidelines, they have not recommended the use of glucosamines. It sometimes gives pain relief. So in practice, we have seen, but that is for only certain patients. Fish oils and chondroitins are the same. So there are actually no unbiased clear evidence to support the use of these. But in practice, we have seen that some patients do respond, do some sort of response, but actually it is not routinely recommended. So moving on to intra-articular options, we have the intra-articular glucocorticoids. So they are very useful, especially to manage flare. So when the patient comes with a flare with the swollen joint with effusion, we can use intra-articular glucocorticoids for quick relief. So when other therapies are ineffective, also we can use, like NSAIDs are contraindicated, or when they are not effective enough to manage the symptoms, we can use intra-articular glucocorticoids. And sometimes we may have to give glucocorticoid injections before we start on therapeutic exercises, because therapeutic exercises play an important role in the management of osteoarthritis. So we can use these. But we have to, when we give the intra-articular glucocorticoids, we must educate the patient that this only provides short-term benefit. So there are other preparations like hyaluronic acid, which is actually now not recommended because there had not been any convincing evidence to support intra-articular hyaluronic acid to be effective in the management of osteoarthritis. Then the other one is platelet-rich plasma. Well, it is also not recommended by the guidelines. That is mainly because there are no convincing trials, because the problem with this is the trials that are used, that there is no heterogeneity in the preparation method. So only problem is that they have been unable to demonstrate a good response to look at. I mean, it had been difficult to look at the trials in a way because there had been a lot of heterogeneity in the preparation methods and all. So at the moment, it is not recommended because the evidence is not strong enough. Then stem cell injections, it is also not recommended at the moment for routine management of osteoarthritis because there are no convincing evidence. So this is just this I've taken from the ACR guidelines. Just a summary of what I've been talking about. So for any osteoarthritis, NSAIDs, oral NSAIDs are recommended, highly recommended, strongly. And topical NSAID, we can use topical NSAIDs. And intra-articular steroids. So this is image guided injection is for hip. So intra-articular steroids are important in the management. So this is paracetamol, tramadol, duloxetine, and topical capsaicin can be used in certain patients. So moving on to non-pharmacological therapies, therapeutic exercises play an important role. So we must direct them towards local muscle strengthening and aerobic fitness programs. So the exercises should be tailored for patients. So it is better to include supervised sessions with a physiotherapist. So we must educate the patient that at the initial period, there may be some pain, and that they would not experience a quick relief with the exercises. So it takes time. Exercises take time, patience, but you must adhere to it. And if you adhere to a long-term consistent exercise program, the functional outcome and the pain relief is very beneficial. So we must. Then again, the importance of education comes here. We must educate the patients before we send them for exercises. So these are few exercises that you can advise your patients on: the straight legs while sitting, or straight leg raises while lying down, the sit and stands, and quadriceps exercises with the roll. So it's better to refer them to the physiotherapist to initiate the exercise program, and they should be tailored to the patients because it depends on the patient's functional ability as well. So the other one is weight management. That is mainly for overweight and obese patients. So we must educate them that any amount of weight reduction is beneficial. So it doesn't have to be a certain amount, but any amount of weight reduction will be beneficial for knee osteoarthritis. So manual therapies like mobilization, soft tissue techniques, that is like taping and all, they can be used alongside therapeutic exercises rather than as alone. So other pain relief modalities like transcutaneous electric nerve stimulation, ultrasound therapy, and interferential therapy, they are not shown to be very effective for the management of osteoarthritis. So we can use devices. So walking aids are shown to improve the outcome of these patients. And we can use braces like tapes, supports, and also insoles for knee osteoarthritis when there is joint instability. There is joint instability, we can use braces to stabilize the joint. And if there is abnormal mechanical loading, we can use braces to correct the loading. And if exercise is ineffective or unsuitable without a device, we can recommend a device for them to carry out the exercises while using them. And some patients, devices may be helpful to improve the function. So this is just a diagram showing how a device can be helpful to sort of unload or to correct the mechanical loading. Here you can see there's a abnormal loading here in the here comes after using a brace here with support, there is correction of the mechanical loading. So this is a summary of non-pharmacological therapy. So exercises are actually very important and highly recommended. So then the self-management programs where you educate the patients on lifestyle modification and then weight loss. So exercises like Tai Chi, they're also shown to be effective. And using a cane is effective for knee osteoarthritis. And tibulofemoral knee braces are very effective for knee osteoarthritis. Then we can use other modalities like heat therapy, heat and cooling for pain relief. And then cognitive behavioral therapy, acupuncture, then can use taping to help, but these are sort of conditional recommended, that is for certain people. So moving on to surgical management, knee replacement. So that is like if the symptoms are substantially impacting their quality of life, if it is impairing their quality of life substantially, then we have to refer them for knee replacement. So then when the non-surgical management like the topical and the oral and the exercises, when they are ineffective or unsuitable, then again we have to refer them for replacement. We have to use clinical judgment rather than severity scores when we are over the radiographic changes before we refer. Actually, it is the clinical condition that should prompt us for referral. But we should not use age or sex or smoking, obesity, and the presence of comorbidities to defer them from the surgical rectum. So the other arthroscopic procedures like lavage and debridement, they are not recommended because they may give acute pain relief, but in long term, they may carry worse effects on the progression. So in summary, management of osteoarthritis requires multidisciplinary input, and patient education is mandatory to improve adherence to treatment and better outcome. And NSAIDs remain the most effective pharmacological therapy, and non-pharmacological modalities are important component of management, and patients should be referred for replacement when other modalities become ineffective. Thank you.
It's time for questions. I think you were talking about knee braces. In fact, but case of knee guards, because the patient moves mostly. So as to what that will be.
So for the first question, Dr. Pishari, hydroxychloroquine is not recommended actually. It has not shown any benefits for the management of knee osteoarthritis. So it is not recommended to be used for the management of knee osteoarthritis. And in the current guidelines, they say there is no place for hand osteoarthritis, but earlier they had recommended, there was conditional recommendation for the use of hydroxychloroquine for hand osteoarthritis. But in the recent guidelines, they have said that the evidence is not convincing enough. So routine use of knee guards is actually not recommended, but it can be used like for, as I said, when they need for the exercise programs, they can use the knee guards and continue the exercises, and the management of flares, that is the knee guards. I think you refer to the knee support, right? So knee support, so it is reserved for management of flares or for short term, not the long term everyday use.
Let's show our appreciation of the consultation. It is time to give so we are open up appreciation to the so let's move further. Very important update on rational use of non-demand medication by Dr. Shanti MBA, MBBS Canal, MD Ministry, Special Mandate, Rheumatology UK, postgraduate assistant medication. She's a consultant rheumatologist, a senior lecturer in pharmacology, a graduate of medicine, University of Glasgow. Over to you, Shanti, for the presentation.
Thank you, Dr. Tushari, and good morning to you all. So I think my colleague set a very good foundation for me to build on, to add on a few other things as we go on. So I'll be talking about rational use of non-DMARD medicines in rheumatology. So let us start with a couple of cases. Patients that we very commonly see in rheumatology practice. So this is a young chap who comes with shoulder pain just for 2 weeks with limited range of motion. He's unable to move his shoulder much as he used to. And there's no history of trauma. We examine him. There's tenderness, particularly over the long head of biceps. And there is a little bit of tenderness of the trapezius as well. We think there's a little bit of muscle spasm going on. Patient number 2, older female who already is a diagnosed patient with rheumatoid arthritis on treatment. Her other joints are quite all right, but she's complaining of knee joint pain, which has been there for a while, for about 3 to 4 months. And the pain worsens predominantly with walking for long periods of time, or standing for long periods, or with climbing stairs. And you examine her, there's a little bit of tenderness in both knee joints. There's an effusion, but it's not very clearly inflamed as such, and her inflammatory markers are also normal. Third patient is a middle-aged female. She's again complaining of neck pain and back pain, but she has, and it has been going on for a while for her, but she has some other symptoms as well. She feels very fatigued. She feels tired all the time. She's not able to sleep very well. When you examine her, her joints are too bad. There aren't any inflamed joints, but she has specific tender points, which we call trigger points, in both an upper and lower body. Again, her inflammatory markers are normal. So these are very common patients that we see in rheumatology practice. So what is the salient common characteristic that you have seen across all these 3 cases? Yes? There is pain. All 3 of them have pain. However, pain can be due to various reasons. It could be inflammatory, like what you heard in the first lecture, or else it could be degenerative, like what Dr. Asanka mentioned about, predominantly osteoarthritis degenerative, but there can be inflammation that comes on later on. Or else it could be neurogenic, where the pain originates from a problem in the nerves, or something due to central processing of pain, which we call nociplastic. And the pain mechanism, if you remember your neurophysiology, it starts with some form of tissue injury for some reason, where there is a little bit of inflammation that happens, and there are chemical mediators that are released that go and act on the nociceptors, and then the pain signal gets conveyed up the dorsal horn, through the spinothalamic tract into the thalamus, and you experience pain. And this is modulated by inhibitory pathways that come down from the central centers into the dorsal horn. Now, it could be acute or chronic, like in our first patient. It could be short lasting or longer, 3 months or more, we call it chronic. It could be of different types, nociceptive, neurogenic, or neuroplastic. And like our first patient, we might be able to, if it's acute, we might be able to identify a fairly, we might be able to identify it's probably the biceps tendon that is inflamed. But like in the second and third patients, if there's chronic pain, it can be a little bit more complex. And why do I say so? It's because when there is ongoing pain, the chemical mediators do certain things. There is lowering of the threshold of the nociceptors, and there's central modulation and sensitization at the level of the spinal cord. There is modulation that happens in the higher centers, in the thalamus, etc. And there is also changes that happen in the inhibitory pathways that come down. So because of that, there is peripheral as well as central sensitization, so that people will perceive stimuli that are not otherwise painful as being painful. So that's why those who have chronic pain have allodynia. And this will lead to a cycle of pain. You perceive something as being painful. If that persists, all these changes happen, so the cycle continues. So if you are to deal with this adequately, and this also leads to other changes. Pain. When there is pain, the body thinks that there is a noxious stimulus. So there is muscle spasm, like in the gentleman with the shoulder pain. The rest of the muscles are in spasm. And there's restricted movement. If that lasts long enough, there's muscle atrophy, there's weakness. And that leads to a reduction in function. And that causes psychological distress, sometimes associated with depression. And with all that heightens the pain perception. So it goes on as a vicious cycle. So if we are to address this adequately, we need to break the cycle. And how do we break the cycle? Number one is we need to assess them properly. Now, all those 3 patients had pain, but they're different. So we need to properly assess them and come to a correct diagnosis. And quite often in rheumatological practice, we need a multimodal approach. Of course, we have our medicines, but there are loads of non-pharmacological methods like what was emphasized in the osteoarthritis lecture that are very helpful. And they need to be reviewed regularly, and the therapy should be adjusted appropriately. So when it comes to pharmacological therapies that can help us break the cycle, one is that we can identify and treat the underlying cause. So that's where our DMARDs, if it's inflammatory arthritis, we opt for DMARDs. And steroids, if it's an inflammatory autoimmune condition, we would use steroids. The other place for steroids is in acute conditions, but there is some inflammation going on, like in the patient with probable tendinitis or a fasciitis or a bursitis. And we can use analgesia. That's the next one. And for muscle spasms, we can use muscle relaxants. So over the next few minutes, I'll be focusing on these 3 classes of medicines and where and when we can use them in rheumatology practice. So now steroids for us is like sugar. We love it so much, right? But too much of sugar is never good, all right? So you need to be very careful on where to use them. Now, for us, it can be used to treat an underlying condition, be it an autoimmune inflammatory condition or an acute condition where there's a little bit of inflammation. Like sometimes even with osteoarthritis, there is secondary inflammation that sets in. Or if there's a radiculopathy and a little bit of edema and pain surrounding it, again, it might be useful. And we all know that steroids work there are 2 ways. One is that it changes gene transcription so that it reduces the inflammatory mediators and increases the anti-inflammatory mediators. It can happen through changing the gene transcription or through a non-genomic mechanism. And there are loads of different steroids. And when it comes to oral steroids, we usually opt for the prednisolone, methylprednisolone, and quite rarely dexamethasone, but their potencies are different. And their side effects are also different because they have different mineralocorticoid or salt-retaining properties. So remember that these are not interchangeable. For example, prednisolone, 4 milligrams equals to 5 milligrams of methylprednisolone, and it should be the other way around. Yeah, and dexamethasone 30 milligrams, right? So we need to do a dose calculation, find out which one is the equivalent dose. And we all know that steroids have loads of side effects. It can affect almost any organ in the body. The thing about steroid side effects is that there is a significant inter-individual variability. And if you give it systemically, that is either orally or intravenously or intramuscularly, the side effects will be more than giving it locally. And there are certain ones that are dose dependent. there are ones like the cushingoid phenotype, the immunosuppression, changes in the skin, which are dose dependent, and they increase as the dose increases. And there are certain ones that increase after a certain threshold, like developing glaucoma or cataract, or developing certain psychiatric manifestations like depression or elevation of blood pressure. And this other important thing to remember is the longer you treat a person with systemic steroids, the greater the side effects will be. And you also must consider whether there's this pregnancy and lactation is also another thing to consider, because different steroids are metabolized differently. For example, the fluorinated ones like dexamethasone are not metabolized by the placenta. So they cross into the fetus in greater concentrations than methylprednisolone or prednisolone. So those would be safer depending on the patient. So something that we need, I'm not talking about treating vasculitis or autoimmune rheumatic diseases. This is primarily for other conditions that we could use it in. Number one, we need to decide on whether we can give it locally or whether we really need systemic steroids. If it can be given locally, for example, just one joint that is involved, or a place that we can inject like the tendinitis, it's always better to go for a local steroid than to give the patient tablets. And if you have to give tablets, use the lowest dose for the shortest possible time. And if you're giving oral tablets, it should be taken in the morning, because our adrenal glands are most active in the morning. So the adrenal suppression will be the least if the tablets are also taken in the morning. And we need to monitor for adverse effects, and we need to manage any pre-existing conditions that might worsen. For example, making sure your diabetes is under control before we go and add on a steroid, or advising the patient about diabetes control and blood pressure control. Another thing to remember is that steroids given for less than 2 weeks at a dose less than 20 milligrams per day of prednisolone is not immunosuppressive. We don't consider it immunosuppressive. So the risk of infections are quite less, and there's no problem in particularly immunization in patients who have been on the short courses of steroids. Now, when it comes to local administration of steroids, I must say that you should opt for it. If you're not trained, please refer. And even if you give it locally, it's not without problems. If you inject into a tendon, it might rupture. And there are certain places that we would not inject at all, like the Achilles tendon. We inject it, it's going to be disastrous. So if you're opting for local steroids, injections in soft tissue or intra-articular, you should either be trained or refer to a person who is trained to do it. Now, the third thing that I told you about is analgesics. Now, we have our non-opioids, paracetamol and NSAIDs have already been mentioned by my colleague. Opioids, we'll come on to that. And another very useful thing are these adjuvants. These are adjuvant analgesics, which are not primarily analgesics, but they do have an analgesic effect in certain conditions. Let's start with paracetamol. Now, this is a medicine that has been in use since the 1890s. Centuries, it has been there. So it is a very old medicine, but for me, old is good. So it's because although it is effective only for mild to moderate pain, and although it doesn't have a significant anti-inflammatory effect, it is very well tolerated and it is very safe. And particularly when it comes to osteoarthritis, I think some studies, particularly Cochrane review, has shown that it has minimal clinical effect, but yet it is quite safe and it's well tolerated. So it can be used well in combination with NSAIDs. For example, if you're giving an NSAID twice a day and the patient also gets pain, midday, you can combine it with paracetamol. And mind you, some patients do respond to paracetamol alone as well. So it is a very safe medicine and it is effective, but not so much for inflammatory pain. But remember, the maximum daily dose should not exceed 4 grams in adults. And if there is renal impairment, particularly stage 4 onwards, we would reduce the daily dose and increase the dosing interval. And in hepatic impairment, again, we'll try and avoid it. But if we have to use it, we will keep the daily dose to just 2 grams. Now, coming on to NSAIDs, my colleague has already mentioned that. We have the non-selective non-steroidal anti-inflammatory drugs and the selective COX-2 inhibitors. The difference is that if it's COX-2 inhibition, there is very little effect on COX-1, which is the constitutively present enzyme, which is involved in gastric protection, homeostasis, and maintaining renal function. So with COX-2 inhibitors, there is little effect on the little GI side effects. And there are some controversies about the renoprotective effect of it, but there is little effect on the gastric side effects. Another thing about the NSAIDs is that there is a very big inter-individual variability. The NSAID that I respond to most might not work for somebody else. And this is because there are inter-individual differences in the pharmacodynamics as well as the kinetics, right? So there are loads of different NSAIDs, a few different classes, and I've just summarized ones that are commonly in use. So, but just like the clinical effect has inter-individual variability, the side effects can also differ between people. And if you look at the different NSAIDs, there are some that are sort of more associated with certain side effects. For example, indomethacin is notorious to cause headaches. We do use it for headaches, certain types of headaches, but it can cause headaches as well. And if you take, diclofenac, it's thought to be one of the highest among those that are causing cardiovascular side effects. And it is also thought to be more hepatotoxic, along with a few others. And things like meloxicam, it has a slower onset of action, but a longer duration of action. And so there are differences between the different ones. And naproxen is thought to be have less cardiovascular effects than the others. So as my colleague said, deciding which NSAID to go for will depend on the patient. And if there is no response to one that you have tried, for example, you have tried naproxen and it's not working very well, it's perfectly reasonable to switch to something from another class. You can try diclofenac. The patient might respond to that better, or vice versa. However, there is absolutely no point adding on another NSAID when the patient's already on one. There's no point in adding on Sulindac on top of diclofenac, on top of something else, because the mechanism of action is the same. There is very little evidence to increase efficacy, but there will certainly be more adverse effects. And a blanket thing about all NSAIDs, in an acute setting after CABG, all of them have a warning. You should not try and avoid it. And in patients who already have renal impairment, again, we should avoid using if the eGFR is less than 30. And as my colleague mentioned, wherever possible, we can opt for a topical NSAID. For example, in the knees, it's quite close to the skin. You can try a topical. If it doesn't work, add on oral. Right. Now, opioids in rheumatology is a little bit of a concern, really. because we do not recommend long-term opioids routinely in patients. And it should be used only if all other therapies have failed or we can't use all the other therapies. And if you're using it, it should be used in the lowest effective dose for the shortest duration of time. And we always try to combine it with another mode of analgesia so that we can reduce the opioid dose and the duration. And we always must bear in mind to continually assess these patients, assess the risk, assess the response, and modify therapy. And there is no compelling evidence of clinical effectiveness of strong opioids over weak opioids. And however, there are studies that show that there is increased risk with it. For example, there are meta-analyses that show patients with knee joint osteoarthritis treated with tramadol have a higher mortality than those treated with NSAIDs or other things. Now, this could be due to different reasons. For example, a lot of the patients that we will put on an opioid, particularly tramadol, will be ones who have other comorbidities like end-stage kidney disease, or those who have had had massive bleeds, or those who have cirrhosis or other organ dysfunction, and we can't use anything else. And they tend to be older, more debilitated, and with higher risk factors. And opioids are notorious to cause sedation. If they have a fall and a fracture, then of course the mortality is going to be high. That's one aspect of it. And the other thing is the side effects of opioids themselves. It causes sedation. It makes people prone to falls, fractures, CNS depression. So that can also lead to increased mortality itself. And from among the opioids, tramadol is considered a weak opioid. It acts only on the mu receptors, and therefore its risk of dependence is much lower. So of them, if we have to use something, we would opt for tramadol than to go for morphine or any other opioid. Coming on to the last group of medicines under analgesics, the adjuvant analgesics. Now, these are not medicines that were invented or initially licensed as medicines for pain, but they do have an analgesic effect, particularly tricyclic antidepressants or selective norepinephrine reuptake inhibitors. They have a good analgesic effect for neuropathic conditions or for those with central problems in pain processing, particularly things like fibromyalgia. Now, if we are starting patients on these, we have to make sure that they know that we are not treating depression, because we know even in patients with normal mood, they have an analgesic effect. And it is very important to let patients know that, oh, all right, these are antidepressants, but they work very well for the type of pain that you have. And we are treating the pain. And because there is stigma associated with psychiatric problems, so it's important to educate our patients. And the other thing is, it'll take time for you to see a clinical effect. So a lot of the problems are the patients also don't know that it might take time for them to respond. The clinicians also not aware, and we keep switching or we keep adding on. So we need to give it enough time, at least 2 to 4 weeks, and sometimes up to even 6 weeks to see an adequate response. And we should not be stopping these abruptly, because if these are stopped abruptly, it can cause agitation and other problems. So they need to be tapered off. Now, other antidepressants, particularly SSRIs, like fluoxetine and paroxetine, they are not a first line for pain. And there is very little evidence to support their use in musculoskeletal pain. So we would opt for a SNRI or a TCA, but TCAs are much more sedative, right? And the anticholinergic side effects are much more. So again, depending on the patient, we can select which one to go for. The other type of adjuvants are the antiepileptics. So it's predominantly gabapentin, pregabalin, and carbamazepine, which are useful in neuropathic pains. And but it is sometimes we do use it for central neuropathic pain or fibromyalgia, but the effect might not be as good as an SNRI or a TCA. Right. So we've spoke about steroids. We spoke about analgesics. And the last bit, I promise I'll keep this short, is muscle relaxants. Now, there are different types of muscle relaxants, but what we commonly use are baclofen, tizanidine, and sometimes benzodiazepines. And there is really no evidence to support its use in inflammatory arthritis. And it's associated with more adverse effects. But in conditions where there is muscle spasm, like, for example, if a person has an acute lower back pain and you detect clinically there is paraspinal muscle spasm and there is a straight spine on the X-ray, then you can opt for a short course of muscle relaxants. You detect a shoulder problem, the entire trapezius and everything else is in spasm, a short course might help. And it is shown to reduce lower back pain in certain populations, and we try and keep the duration of treatment short. And we need to balance the side effects versus the benefit. All these are sedative, number one, and they are muscle relaxants. So there is a degree of weakness that will come on with them. So if you overtreat, you're making a person absolutely fluffy, right? And they'll feel terrible. So there's a fine balance that you have to strike if you're using these. So coming back to our three patients. Patient one, I'd say there's a clear diagnosis. It's a tendinitis, a bicipital tendinitis. So what is the best way to treat this patient? I would say, if the patient consents, I would give a local steroid injection into the along the sheath of the bicipital tendon. There is some muscle spasm, so sometimes a little bit of oral analgesics, a little bit of a muscle relaxant, maybe tizanidine for a short duration of time might help for the patient to regain function, to break that cycle of pain. And then patient two, it's a patient with rheumatoid arthritis. Only the knees are painful. It sounds a lot like an osteoarthritis along with the rheumatoid arthritis than a flare of the rheumatoid arthritis itself. So would it be justified to start the patient on oral steroids and increase the DMARDs? I'd say no. If the patient is willing, I would rather inject the knee joints, aspirate diffusion and inject the knee joints, give a short course of NSAIDs if there are no contraindications with a bit of paracetamol, and try and get the patient back up again. The third patient, widespread pain, loads of tender points, poor sleep, fatigued. This is the classical patients that we see with fibromyalgia. So it's a problem with central pain processing. There comes up adjuvant medicines. I would probably start an SNRI and review in about 6 weeks or so to see if there's a response. And patient education in these cases are very, very important. So, in summary, when it comes to non-DMARD medicines, there's no one-size-fits-all, right? You need to properly evaluate the patient, and we need to find out why exactly is this patient presenting with this condition? Why is the patient having pain? And what we select out of all the medicines that we have in our pocket depends on the patient, depends on the diagnosis. And sometimes we need to take multimodal approaches. We might have to combine, but we need to be careful to avoid unnecessary polypharmacy. And another aspect of using them rationally is to review these patients regularly and to adjust therapy as appropriate. Thank you.
Thank you, Priyanki, for an excellent presentation, taking everything together, putting into very basic levels and elaborating the case of functional management. So, I think that it's the last lecture. If you have any questions, I will come to ask some of you.
Thank you very much for that excellent presentation and also for taking us back to the case. I have two questions for you. One is, what is the place of pulling back in renal? Is it safer than the other effects? That is the question. And the second one is that when we use topical analgesics, let's say we are using a phentoxin, is there a rationale of using diclofenac? Why? Because I mean, if we are using a diclofenac, it's a topical NSAID is also a diclofenac. Is there a useful? Right, that is that one. That is
To answer your first question about Solindac, it has gone out of use because it does have a lot of other side effects. And I also know that it is traditionally used in patients with renal impairment. But to the best of my knowledge, there is no proper evidence to say that it is much safer in patients with renal impairment or those who are prone to get renal impairment. And to answer the second question, now, if the patient has the whole point of multimodal management and using different modes is to cater to whenever the patient, one is to prevent pain from happening so that we break the vicious cycle, and if the patient gets breakthrough pain, to address that. So if the patient is on twice a day diclofenac, gets an ache or a pain somewhere else, then of course there is a place in using the topicals on top of that. And number two, the second point is that the onset of oral NSAIDs, the onset of effect of oral NSAIDs will take a little bit of time, at least an hour or more. So in that case, if you want acute pain relief, and if the site of origin is very superficial, then the onset of action will be much quicker with a topical application than with the oral one. So it's about sort of fitting it into the patient. But yes, there is a place in visit.
One more question from Priyanki. Now, the costs are really concerned of these players. When you start understanding this, there is the mass of combined.
I personally would ask the patient and assess the risk of dyspeptic symptoms and whether they anyway experience GORD symptoms, dyspeptic symptoms. I would put them on a PPI. If not, if it's a COX-2 inhibitor, I will try with just the NSAID alone. And then again, other high-risk patients, those who are on aspirin, or in elderly, again, I would put on a PPI along with the NSAID. So it depends on the risk that the patient has to develop dyspeptic symptoms as well as GI bleeding.
Regarding pediatric patients, but then out of these four groups, I most prefer analgesic group for pediatric patients.
For JIA, if it's JIA, we will have to go for an NSAID. And if they're not responding to NSAIDs, then we have to escalate treatment because JIA, there is no evidence that anything else would work. And with JIA, we need the anti-inflammatory effect to be there for treatment.
Yeah. Out of this energetic group, NSAID group,
NSAID.
and it's much more preferred.
Yeah.
Can we use this repeated?
Yes, it can be used. So I think traditionally, different people would prefer different ones. But I know that some opt for naproxen because it's relatively sort of more tolerated. But any of these can be used, but it depends on how comfortable you are with it and the other side effects of it.
Thank you.
Thank Kiran based on intro application and usual ways. Dr. Kiran will be able to explain. So, now.
Thank you very much.
That concludes the first session. Thank you very much to all the presenters and to the members of the head table for enriching us with the knowledge. So before the next session, we will have a small tea break to refresh ourselves. So Matale is a unique district that is imbued with rich history and abundance of natural beauty and all kinds of climates. So while we enjoy our tea, Dr. Rasika Katugaha, an RHO from the Rheumatology unit, will be doing a small presentation about Matale and its history. We'll resume the session at 11:05 a.m. Sounds on it?
Hi, boy. Let's have a walk in Matale. Matale is one of the three main districts in Central Province, closer to the center of the island, where the Nalanda Girige Vihara is located. Matale was one of the earliest human habitats in Sri Lanka, running back to prehistoric era. Laggala, which was referred as Lanka Pabbata or Lakegala in historic records, was the capital of Rape in Ravana. Evidences say that Matale was the home for Yakka clan of ancient Sri Lanka. According to history, King Pandukabe handed over this area to his uncle, Prince Abaya, hence Matulata Pavarupuraya later became Matale. Matale also refers to the flat land or Mahatalava surrounded by Nakal, Punnasgiriya, Burulu Hill, and Ovilikanda mountains. Matale is gifted with a diverse ecosystem and a pleasant climate throughout the year. Reign of Sigiri Kashapa was the most flourishing era of Matale's history. However, throughout the ages, Matale served as an important landmark between Rajarata and Malayarata. During Kandyan era, Matale was declared as the main reserve. Halapola Valawa, Kapatipola Valawa, and Gunuvila Valawa are three living evidences of its rich heritage. During the Kandyan era, Matale was although it was governed under Kandy during the British era, under Kandy, it was reconverted into a main district in 1954. Historic Matale Kerala in 1848, led by Gongalebada Banda, Veerapuranappa and Kudapala Hamguru, reflects the faith of people towards the motherland, making Matale an iconic landmark in struggle for the independence. Aloka Vihara or Alu Vihara adds a global significance, which was considered to be the sacred land where the Tripitaka or the sacred doctrine of Gautama the Buddha was transcribed during the reign of King Vattagamini Abaya. This city is home for a diverse community, including all races, all religions, and all social classes. Sri Muthuammari Amman Kovil is considered to be one of the tallest Hindu temples in the island. Annual Teru festival is one of the eye-catching events in city's calendar, where devotees from all corners of the island gather to pay homage to goddess Pati. Laksha, Dumbarapedru and Braswell are three main areas where people of Matale exhibit their talent in art. Kapuvida is one of the remaining villages with original Laksha in Sri Lanka. Not only in art, people of Matale had excelled in medicine too. Sapuvida, Valmorue, and Murutolue were three famous generations, while Navaragada Thero and Halalpitiya Thero were famous doctors in indigenous medicine. Western medicine was introduced during the British era to cater the health issues of Indian estate workers. In 1822, Central Dispensary of Aluvihari was established as one of the very first quarantine centers in the island. Health facilities were broadened with the establishment of coffee plantation, spreading of communicable disease, and epidemic of malaria. In 1871, foundation stone was laid down for Matale District Hospital. Today, the District General Hospital of Matale serve a great part of the community in curative and preventive health sector in Matale and nearby cities. We hope this regional meeting of rheumatology and rehabilitation will be an iconic event, plus the source of light of modern medicine to the world. Thank you very much.
So you are all right with this one?
Hope everyone is back in their seats. Now we'll start the second session. Before that, appreciation to Dr. Rafika for that presentation. To chair the second session, which will consist of 2 lectures and 2 case-based discussions, I cordially invite Dr. Gunendrika Kasturiratne, consultant rheumatologist at NHSL, and Dr. Manil Piri, consultant chest physician at Matale Hospital, to kindly sit at the head table. Now I hand over the session to the head table. Thank you very much.
Good morning, everyone. We are just about to start the second session of the program. This section will be done by Dr. He is a consultant in rheumatology and rehabilitation, currently working at the District General Hospital, Marble. He is going to talk about the movement of back pain and posture, the guide to back pain and posture. Over to you, ma'am.
could you just for sense, can this you are also if that's possible. For those who do not scan the QR code, which even you can use if you are using a Samsung phone, then this is drop down menu, you will finally scan QR function and it's in Android phones. And if you are unable to do that, you can go to settings, click on the QR scan facility, and then take a photograph of this. If you are unable to scan this, I have an envelope with a few slips QR code as well. So if you are unable to do your order, you want this process, you can just there are things. If someone able to do for most of you do not have an easy flexibility, so for some shoulders, so like they can see your shoulders being lifted. So take consider this as an exercise as well. Before myself. So this and they will have a link, right? You can even go that link as well. Taking a photograph of me or the people as well, taking the phone, definitely. I can see some people never use the QR scanner facility. There may be still that maybe your phone, but still please come. For those who do not know how to scan, it's all right. But now, shall I just pull? Yes, I. So, while you scanning this, maybe slightly switch the slide so that it will. So now, any opinion, my question, I will show you photographs. Famous for the good or the German chancellor. This is this is Winston Churchill. This is the famous rolling line portrait taken by the famous photographer. And this is Mahatma Gandhi. And again, that you want to so you can see the most powerful question so that I can so I think most of you might have selected that. Have you selected the just maybe try to questions in your responses. So, so 60% of on these regular and 20% but anyway, you can just I just wanted to highlight the lecture, you can still so these are the things therefore you can pass this on. So I'll show you the lecture so that you might be wanting what I know now. So in your opinion, what is the most powerful question? So these are some of the questions of rotations of certain popular again. What are the things? Even the angel with this hand gesture of became quite rotate. What I intend to cover in this lecture, now I will do unorthodox or like a very unusual mistakes of the traditional lecture that I was supposed to do. So the science behind question, how should we stand, how we see its evolution and investigation was sent treatment of practically from how posture defines us. Now there's this thing called posturology of American Academy of Orthopedic Surgeons. They have given the definition for posture, which I am also unable to understand. But anyway, this is the portrait of pieces of one of the study. So your posture. So there are science behind the posture. There might be visual, vestibular, physiosensity, tactile, not sensory inputs. That might determine your posture. And now there is this thing called CNS posture, which creates an input to mainly the lower half of your body, the trunk and the lower limb muscles. It's very simple as it sounds. So there is a very complex feedback involving posture. I'm not going to explain these things, but the big question is, because resting they from person to person. So, there are major issues, preference and adaptation. From legal side, all the neurological travel and the things it was to consent practice because they are more question to the environments of science supervised. So that's an important element. I'm already covering today. Now, what we do when we are working, running, swimming, cycling, in robotic something, I think that's an important study. We can say exactly what we are doing in the market. How you hold yourself, we are very much more. Statement is 65 years. I'm not talking about the economic age, by the way. Then three foundations of the spine, 479 and 5 years. Looking at the postural function, meetings and evaluation, must statement is 65 years. Cover some 65 years. So function of the sensory system is gradually, and there's this reduction of sensation and vestibular function. And then people rely more and more on vision. But then again, the vision also fails. Then comes the six, the click, and the point. 65, research has shown that 60, between 60 and 70s are more unstable than the electoral person surface with their very slow. So if I bring down the age to 50 years, instability was the same instability was evident at the age of 50 years onwards. When a surface was introduced, again on bilateral surface, with high slope. 40 years, the same instability is reintroduced. The single unit star was tested with isotopes on a point surface. So as we age, we become unstable. So this is the most preferred standing leaning on one leg, which I am doing right now, and with the other bed. Points curvature, the body level, the one. I won't go into detail about my name, because I might be forget about me. Anyway, so these are some of the photographs which I have used. Now these are some of the sculptures, the things which might have been using live models. The live models because it is single posture because it's stable. So same thing applies to work in a group of over years. So this is where you find around complex. As you can see, what we want to illustrate is one leg of students. So why not whether they use models to carve out these? But so I just want to show the same posture. These are very comfortable posture. So a comfortable posture. There is exercise posture on one side. You know that the buttocks and the knee. The solution is to same sides. So then there are the balance. So there are certain maladaptive posture that hyperlordosis is but maladaptive posture. There is this pronounced lumbar lordosis. And this is the opposite of that is a friend posture where the pelvis is party, the lower back is straight, the lordosis is flat. There is forward stooping, and there is difficulty in standing for long periods using this maladaptive posture. There is smooth shoulder. So we have the knuckles face forwards, indicates a tight fit, again an uncomfortable posture. What is the correct way to stand? So this should be the healthy alternative. The shoulder joint and the hip joint are in the same corner. To speak for ages of Christian ergonomics, I won't do that. Whenever I go to some place and see a complex check the levers, and I can show some those levers. Those levers are there with a purpose. Even the compressed scale, everything is there with a purpose for you to adjust. So make sure that you adjust your question and extend your usage. So all this done with a purpose, and then there's a separate topic for a separate speech about that. What is the purpose sitting? The shoulders should be over the hip. Support. Then your elbow should be at 90 degrees. The feet will be on the footrest with the enough space between the knee or thigh and the seat to be moving. The head position should be aligned so that the ears are in the same plane as the shoulder, and finally everything should be within 1.5 feet of your hip. Slouching, I love slouching. I can see a lot of people slouching now, but it doesn't always comfort. But over time, this position can play strain on already sensitized muscles. So insurance is really is not unique to us. It's from your posture. You flex your hips, knees, and ankles to the extreme. In first practice, you can't do it in first day. It's unique to us. So something which is unique to us, it should be there. So, certain particular issue that imagine I know a meeting, people and I'm going to do something like a consumer meeting, right? Exactly as this mark is perfect. Not will be doing this because there's only one is only in the newspaper. So this is a new posture, the posture which can go starting to that way. Then the team chicken posture is somewhat the opposite of the previous. Posture is also again reductive and it can go straight for the chest muscles. So these are some of the posture that you should be using, especially when you are using the bars. When we were in a C-shaped spine, then we had this changing head thing, the milestone, the first reverse which was given was not the given thing with the spiral spine. And then when we attempted to stand, let's say around 10 months or 1 year, the second reverse curvature given over the lumbar spine region. So the concentration of spinal abnormalities and these reverse curvatures is striking, right? So there are intervertebral joints. But this 20% or less of that entire length is associated with the highest incidence of symptoms. The reverse curvatures are an its most convex area. So the cervical and the lumbar spine is 20% of the body is associated with the highest incidence of symptoms. So, however, number of this is unique it helps us in our right position. So when we use reverse curvature, we speak about our times in past. So this is my favorite slide. So I show you our gateway like the bishop. Now bishop has several notations. I'm going to just going to concentrate on this one notation. The old world monkeys had built lumbar spine transverse processes originating from the vertebral body directed anterolaterally. And these function like muscle attachments, enabling the old world monkeys to move sideways and bend forward. Suddenly, more of the sudden rotation. The transverse processes migrated towards the vertical and inherited from the sides, right? Suddenly, we had this number of diseases. Imagine the situation, a mutated clan of monkeys among the old monkeys. We now also they have this advantage of seeing or approaching, seeing only enemy approaching from they will have no practical skills, so that's why they needed continuation, then they so this how my transverse processes migrated from the third dimension to third dimension in motor from external third dimension in sapiens. This migration being overnight by the way. It was spontaneous migration of the movement of posterior superior alien pointing towards the posterior alien, so that gain the number of processes further enhanced. These are places actually leading person literally worldwide. We need to classify different areas specification methods to specify possible payment. Like we only speaking about mechanical and payment molecular, but there are other reasons that impose pain. Informative pain for separate lecture from the one of this and now looking for the pain, there are three main they could be degenerative, it could be conceptual problems, it could be terminate issue. So, in these reasons, these feature shows. Show this. the lower part hole, and focus leading acidification. Now, there is this research joint, which I want to highlight. Now, there are three joints between any vertebrae, the intervertebral joint, as well as two research joints. The research joints are not made to the other way. They are there to prevent an exchange of motion and resist over displacement of the vertebrae. But what happens if the intervertebral joint begins to damage the intestine? Only weight bearing series with the small fragments. It's not benefit. So the essential extra pressure also become ossification and some osteophytes can which can narrow the neural function and also become pinching of the nerves. And those reticular protein the essential itself can put. So there are two reasons why the joints can put. So mechanical amongst people because within 6 weeks, regardless of the treatment they receive, but some experience persistent pain for a year. Here there are three main causes of pathology these again it's a joint issue can cause and also spinal stenosis can cause so naturally causes medical most experience significant improvement in their symptoms within 6 to 12 weeks with conservative treatment. Less conservative treatment with physical therapy, pain management, and exercise therapy. Small percentage might require surgical intervention and very the wonderful thing is 2/3 of the hernia and lumbar discs undergo significant resorption, more than 50% resorption within 1 year. This is a very simple chart showing inflammatory back pain, the difference between chronic back pain and mechanical back pain. As you can see, usually the age is less than 45 or 40 years. In inflammatory back pain, onset is insidious and exercise can improve pain. This can just improve pain. Actually, there is a bit of movement sickness, which is moderate and persist for inflammatory markers are raised in inflammatory back pain, whereas in mechanical back pain, it should be normal. Examination is not anything from discothetic diagnosis. And if the pain comes with a delay, after the injury comes the delay, after strenuous lifting, it comes the delay, when it is chronic pain, it can come as spinal muscle pain, even the strain, the joint up. So in this particular document, big issue in young people and the muscle is handled. And it is an activity that lowers the spine. It's better if we compensate in when you is better. Spine muscle ligamental strain happens within days after strenuous activity or due to an injury, so 1 to 2 days after the incident, it's no and the body creates a hypomobile area because muscle spasm around the injuries area. Essential exposure local pain could happen within months or years. Simply, and seen in an elderly person versus standing and there's less pain you will see that particular pain, again could be non-set, it is herniation, could be insidious as well. Now distribution should follow a normal pattern. So that is it. And it's versus anything that goes to the intra or intra patient. The diagnosis now early imaging has not been shown to improve the outcome. The patient is at zero radical pain. So there is by the physicians. Immediate imaging is only indicated for immediate. If there is major risk factors of cancer, if there is a suspected spinal infection or slash of while or severe neurological disease. So lumbar spine. Do remember to look at the first joint which are following snake-like areas coming from top to bottom on the side of the spinal responses, which you can see in a first joint. You can see these calcified borders in the X-ray. You can see them. Diagnostics. Now we can confirm and we can clarify so existence of radicular protein and the liver. So radicular diagnostics is useful to confirm
And therefore, it is very strong verify root that was diagnostic injections are mainly diagnostic. They might not be therapeutic purpose. So, the cassette injections are sometimes used, and even steroid injections are used. The effects are slow to relieve. Usually, management, the common pressure management includes these categories of drugs. Should be used as first line. Immunotherapy are the first line of use first line, and for back pain, the most famous drugs are ibuprofen and naproxen. And they are effective in reducing pain and also inflammation. What is frequently used other than ASI is paracetamol is prioritized and used in combination with ASI companies and muscle relaxers, and inhibitors, opioids, anticonvulsants are also used. So, multiple relaxants, these are the drugs that are used commonly. Now, the evidence for their efficacy, especially on the long run, is limited. Is preferred in the acute in chronic back pain. It's categories of antidotes that are used, amitriptyline or tryptophan and duloxetine vaccine. So they are between like studies that show their effectiveness in reducing back pain. Then prescribed antidepressants for back pain. Chronic spontaneous pain is considered in between. Highlighted on the right side. This perceiving and legal inspired for patients for which the antidepressants were based. So that is the reason why antidepressants are commonly preferred. Chronic spontaneous pain. These are often pain relievers, but the long-term use of opioids is uncontroversial. It's very organs and overdose may be useful for severe and acute pain. Since now it's used in chronic low back pain, especially for patients who have neuropathic pain. Again, long-term efficacy at the evidence is limited, and they can do but side even no muscular. And simple therapy is very useful. I will just speak about exercise for now involves the use of specific exercises to strengthen the muscles of the back instead of stretching the back. It also improves flexibility. It's substantial of the effective in reducing pain as well as improving function. It is very improving function of the relation the person sitting in front of you will feel back pain. Why download these from versus arthritis, what are the various exercise logic that you could use? Therapy, involves the use of hands in mobilizing or manipulating or massaging the areas of the neck. And it again has been researched to want to be effective in reducing pain and improving function in patients. So this is how spinal manipulation is done, to be done by a trained person, right? And electrical stimulation is the cutaneous electrical nerve stimulation is the most popular type of electrical stimulation that is used. The effects are short-lived, but it is used because it's a non-pharmacological method, and people prefer this over most of the patients. Reinforced innervation is associated with sustained pain relief in patients who have radiculopathy-related back pain. The treatment modalities as well, the therapy, traction. So these are also used. Therapy. But then small but statistical is just a single study where small but statistical significant reduction in back pain was achieved. Now, the acupuncture is where you exactly take the area showing Chinese states of payment. Acupuncture is where you randomly do. So that's what done in Sri Lanka is And so it's has been shown to be effective, a very small improvement in reducing contact rate. The controversial topical name is I was asked not to do this, show these slides, but then I thought of doing. So increased heel height and decreased heel width are predictors of a negative outcome when it comes to back pain. So what does a high heel do? It just creates what we call an attractive posture by creating a prominent calf muscles. There's a bit of recurvature, the knees are slightly curved backwards. There's a bit of lumbar lordosis. What the evolution did, it's enhanced by what most people said. I wonder how orthopedicals would feel that time was put on high heels. But anyway, if the chest is pushed forward, so it creates a question comes in body. So I could scare the whole out of you by showing the point, but layers total linking these two. So I recently showed this to my 16-year-old daughter who wanted high heels and she gave up the idea of wearing. So anyway, so he just want to show the box on the left side. I'm sorry for the clarity. So it shows the incidence of pain, the amounts of pain by for various heel heights are shown. So anything about 3 inches is disaster. But shows it. There are certain proteins I like to see show the then I'm also very minded because even if you look at your shoes, you are at least on each side, if you are a short person, so the ladies can have a long in movie, the 14 was the person who introduced life, right? So again, the ladies can have a long So he's the person who first used the legal by DGH to go to historical. But anyway, certain ideal solution for everything. So you can get ideal for long period of time. You can do because stretching people putting so even shows in the moment when the pain will is honest. It's recommended. Everybody will do that. But then monitor shows, I think it's the fashion. No, but I don't think that the penalty of the woman so it's again don't go for this. It's okay. What science they are to work. So most of the lady, of course, work in UK because 3 pairs of shoes they might be buy those also. So one can go to one can do all the things. One can running shoes. They are doing all class where you can run into. So and what defines a person is this posture. Very different question to answer. So these are some of the world famous photographs defining question and like actually personality. Famous for body language. It's a very nice video on how your body language may shape who you are. Okay, you can just go through that. So now some references. Yes, yes, to see, just to see how they do it. Sorry about this. This fine. So again, standard people, different other people. So when you have so it's 60% of the responses are for the way that so they feedback so my
thank you very much, Hemanta, for the interesting lecture. And I'm sure there may be some questions or comments. Body language, body
Yes, so can financing ways and people can use certain Mr. Rajivan this you can use the world famous photographer their research was taken by also yes, a famous photographer. Now the Churchill was smiling at the family, so he wanted the Bennett more than Churchill to look at the family, but the photographer he was. Put on this. I told photograph just for instance. So one of the photographer he was a leader for the book race. And yes, it's my presentation. But I think to only no. Yes, you can use it. So this photograph was taken by so this photograph which I showed earlier. So there's a similar photograph of him smiling. Like him smiling, and then he was holding a cigar on his right hand. The cigar. He was like to change. One photograph did was while holding on to the wire, what we call the trigger. He suddenly removed the cigar and threw it away. Instant so he got mad at the photographer and he was moved to like scroll the photographer and that's the instant when he got this. So it's again example how you can like create but he has studied the postures in surgery, but yes, posture, personality, everything can be equally. And unfortunately, I do not know how to explain this, but I feel that it's a different topic which I'm not the best person to discuss.
So thank you very much, Hemanta. So we'll move on. Let's thank the first. Thank you, Hemanta. Hemanta, can you please come forward? The next lecture is Rheumatology Beyond Joints by Dr. Patrina Mugla. She's in rheumatology and at DGH Matale.
Oh, I'm again, Mike.
Thank you, sir. So from morning, we have been talking about joints, and joints. So you might be really wondering why all these rheumatologists are going behind the joints, and then why we are so much interested in rheumatology. So I'm just going to take you away from joints just for 20 minutes. So the topic, as the topic says, I'm going to deal about a list of connective tissue disorders here. So these are the topics I'm just going to give you a bird's eye view of these topics because they are very, very vast. So what is autoimmune connective tissue disorders? So they are diseases that is caused by overactivity of our immune system, and which could destroy our own tissues and connective tissues, cartilages, by demonstrating various types of antibodies. So these diseases, why it is important to know, because they could evolve quickly and they could be even fatal. So I would start my lecture with a case. So actually, this was the reason that I selected this topic. So this is one of my patients I met a couple of months ago. So she's a 16-year-old girl who was diagnosed to have SLE 6 months ago, and she was stable on immunosuppressive treatment thanks to my previous colleague, Dr. Pasindu. So she never had Raynaud's phenomenon. But all of a sudden, she developed a widespread rash with a lazy pattern for 2 days duration. So with that, 2 days later, she started to notice severe pain on her right hand, middle and ring fingers with some sort of dusky blue discoloration. So she gave me a call, but this was in an evening. So she was quite far from Rheumatology hospital. So I said, go to the local hospital immediately and admit. So they were a bit educated people. So they immediately went to the nearby OPD hospital, which was a district hospital. But then MOPD has seen her and then sent without even checking the saturation of her fingers. And she was reassured. So then I called her back, and then I was so disappointed. So next day morning, I have to got her down. I got her down next day morning to Rheumatology hospital. Immediately we admitted. And then the picture on your left shows some bluish discoloration of her ring finger, which is not very clear here. Then we did a Doppler scan on right hand, which showed a 3.6 centimeter thrombus at right brachial bifurcation, completely occluding the ulnar artery and partially occluding the radial artery. And thankfully, the circulation was maintained by collaterals. So the limb was salvaged because of the circulation, the collateral circulation. So we immediately admitted her to the surgical ward, and we started on enoxaparin, and then patient was transferred to vascular unit Kandy. And on the same day night, patient underwent thrombectomy on an urgent basis, and the limb was salvaged. So she was then commenced on warfarin, and we started managing her as SLE plus antiphospholipid syndrome. So already she had a diagnosis of SLE, antiphospholipid syndrome was added to the diagnosis now. So this case, this is not to point out somebody's error, but I think it's basically an unawareness rather than a medical negligence. So that's why I thought I would just do an overview of the conditions so that you, when you come across these kind of patients, you know to refer. So first case, systemic lupus erythematosus. It has a different spectrum, from cutaneous to systemic, drug-induced and neonatal. And out of these spectrums, systemic lupus erythematosus is the most common and the serious form. So let's have a look at cutaneous lupus. We have acute, subacute, and chronic forms. So acute cutaneous lupus, what we usually call, you come across like butterfly rash, which could occur suddenly, and it could commonly involving the face, but it could also involve the extensor surfaces and extremities and upper chest. But the rash could even last for days. Usually, these predicts the exacerbation of the underlying disease. So these are the pictures. I particularly selected Asian pictures because the rash in white is a bit different from our setup. So you can see angry looking rash on anterior chest and face, and then on extremities, as well as the chilblain lupus on hands. So this is acute one. And then subacute one, it could appear like the acute, but then it takes a little bit of like slow course, usually involving the neck, shoulders, upper chest, back and extensor surface. Usually it comes as like papules and plaques. Sometimes it could be mistaken for psoriasis, erythroderma, and other benign dermatological conditions. So these pictures show, you could see annular polycyclic rash on back and extremities. And this is most of the time it's subacute. And then the chronic cutaneous lupus, often it is called discoid lupus erythematosus, where you get discrete lesions commonly seen on face, scalp, behind the ears. They have a erythematous violaceous borders. These could progress very slowly and could last for years. So long-standing lesions, we could see atrophy and central scarring. So these are a few pictures of DLE among Asians and another white person on the right lower lower picture. So among the mucocutaneous manifestation, oral ulcers are very common presentation. So you can see various types of oral ulcers in buccal mucosa and palate. And then there could be certain coexisting conditions like gingival bleeding or oropharyngeal candidiasis as shown on pictures. So SLE is usually manifest in the age of reproductive age group women, and unfortunately women are 9 times more affected than men. But then when men get SLE, sometimes it tends to get a bit of like aggressive course, and there could be more photosensitivity. So I'm not going into detail about systemic manifestation. So beyond the mucocutaneous manifestation, the common systems that are affected are cardiovascular, kidneys, hematological system, and lungs, but then invariably joints, we know that it's already affecting joints anyway. So anyway, it could affect any system at the course of the disease, but these are the common systems. And then it's common to get vasculitis. So when there is vasculitis, it could invariably affect any systems. And then thromboembolic disease could coexist when there is presence of antiphospholipid antibodies. So it is advised to screen for coexisting antiphospholipid antibodies in all SLE patients. So this is the new EULA-ACR criteria for classification of SLE. So when the patient meets the classification criteria, the SLE was diagnosed. But then all these criteria, as Dr. Utpala mentioned, classification criteria are there for mainly for the research purpose. So we could not totally rely on these for the diagnosis. So when there is definite criteria are present, you could classify the patient as definite SLE. But then what if they don't meet the criteria, but they have most of the features, then you go as probable SLE. But then the patient comes with few clinical features that are suggestive of SLE, and it might be evolving disease. Then you think the patient is having possible SLE and start the treatment. So moving on to antiphospholipid syndrome. So it is an acquired autoimmune disorder that usually manifests as recurrent venous or arterial thrombosis and or fetal loss. So the most highlighting feature is hypercoagulability. So because of this hypercoagulability, it could affect many systems, including CNS, lungs, renal, cardiovascular, and eyes. And then, as I have already mentioned, the patient could have livedoreticularis, digital gangrenes, and cardiovascular valvular heart disease, and also coronary vascular disease. So these are the pictures you can see in. You can see the lazy pattern rash of livedoreticularis, and then fingers shows subungual, splinter hemorrhages, and then digital gangrene. So next I'll move on to my second disease. This is about a 76-year-old lady who had progressive skin thickening and Raynaud's phenomenon for many years, and had been diagnosed as systemic sclerosis around 6 years ago, and she had presented late to the clinical setup. And then patient had been commenced on immunosuppressive treatment, which retarded the skin progression to a certain extent. Over the years, she has developed all the complications related to systemic sclerosis, including interstitial lung disease, pulmonary hypertension, GI dysmotility, recurrent infections, and worsening Raynaud's phenomenon. So recently she got admitted with worsening of shortness of breath, and she was diagnosed to have congestive cardiac failure, and she was treated and had a good response. She has unhealing digital ulcers, and very recently we gave IV prostacyclin infusions for severe Raynaud's, and it improved her circulation of hands and improved her symptoms. So this is my patient. So you can see the characteristic faces where you have thickened skin, perioral puckering, thickened skin of face and limbs, and then resorption of distal phalanx and digital ulcers. So what is systemic sclerosis? So it has a different spectrum. So starting with limited cutaneous, then diffuse cutaneous, and then there's a transitory form, and then there could be a presentation which do not have any cutaneous manifestations. So this is divided, classified according to the skin involvement, where you have limited form where the skin thickening is limited distal to elbows and knees, whereas in diffuse form, it is involved in the trunk as well. So face and head and neck could be involved in both types. So what are the involvement? Basically, limited ones, usually they have more cutaneous manifestations like calcinosis, Raynaud's, atherosclerosis, but it could even be seen in the diffuse one as well. As you see, calcinosis, arthritis, arthralgia, pulmonary fibrosis, they are all seen in both types. But then pulmonary hypertension is more commonly seen in limited one, and it could present in early stages in limited one, whereas pulmonary fibrosis is more common in diffuse one. And then tendon friction rubs are more commonly seen in diffuse ones. And then moving on to the antibody types, like anticentomia antibodies are commonly seen in limited, whereas anti-SCL70 antibodies commonly present in diffuse type. So just to previously the limited one is called CREST syndrome, but now we don't usually use that term, but it is easy to remember for the MCQ purposes. So CREST is like C for calcinosis, R for Raynaud's, E for esophageal dysmotility, S for sclerodactyly, and T for telangiectasia. So you can see the calcinosis cutis, and then extensive calcification on subcutaneous tissues on these X-rays. And then these pictures show, the typical triphasic discoloration in Raynaud's phenomenon, and then dusky discoloration on an Asian patient. So these are the signs we see in advanced cases. On your right lower corner, you can see early stages of this systemic sclerosis where they present with synovitis and edema of hands. And then you could see the shiny, tight skin on fingers. And then they progress to involve tightening of skin, and contractures develop, and then they get deformities of joints with terminal phalanx resorptions. And finally, you get this prayer sign. So a nail fold capilloscope is used for diagnostic purposes as well. So you can see a periungual capillary loop dilatation on your right, and then multiple telangiectasias on left. And then on advanced cases, you can see like taut mask-like faces with nasal alar resorption, and there is loss of subcutaneous fat leading to tight, taut skin, microstomia, perioral puckering, and then telangiectasia. And then the lower picture shows speckled leukoderma of hands. And then, as already I have mentioned, the changes that happen in fingers. So systemic sclerosis sign scleroderma is where you get internal organ involvement due to sclerosis and thickening without any obvious skin changes, and it's quite rare. Okay, so I'm not going into detail about the multi-system involvement. I have already mentioned, there is pulmonary, cardiac, and GI involvement are common, in addition to the musculoskeletal and cutaneous manifestation. And we all have heard about the scleroderma renal crisis. So next case, this is a patient I managed during my SR period in Kandy, where a 43-year-old male presented with bilateral ankle joint arthritis, episodes of diarrhea, and lower back pain. Patient was made a diagnosis of seronegative arthritis and commenced on sulfasalazine, and the arthritis improved, but then patient had persistent diarrhea. So we were investigating in the line of IBD, inflammatory bowel disease. But then while he was in ward, all of a sudden he started to notice lower limb weakness, and blood investigation showed hypokalemia. So we thought initially like, okay, fine, the patient is having diarrhea, so probably this is due to GI loss. But then that was soon after my MD, so we were so fond of potassium, metabolism. So I did a urine potassium, and it was high. Then we did a ABG that showed metabolic acidosis. Then he was referred to renal team, and a diagnosis of distal renal tubular acidosis was made, and sodium bicarbonate treatment was commenced. So then further investigating for the cause of diarrhea, we found the patient is having thyrotoxicosis. So the patient is having a little bit of like multiple autoimmune diseases here. And then we suspected that this could be Sjogren's. So we proceeded with a minor salivary gland biopsy, and the Sjogren was confirmed. So what is Sjogren's? Sjogren's is mainly autoimmunity against our own glands. So the common symptoms are Zika symptoms, dry mouth, dry eyes, due to lymphocyte infiltration of exocrine glands, and unfortunately, it too affects commonly women. So the median age of onset is 50 to 60 years. So it could be either primary or secondary. The secondary ones are common, where it could be associated with rheumatoid arthritis, SLE, and systemic sclerosis commonly. Viral infection like HIV, HTLV too show similar presentation. So anti-Ro and anti-La antibodies are commonly present in Sjogren's. So Sjogren's, because it could affect glands, still it could affect any systems, including pulmonary, renal, like renal tubular acidosis, interstitial nephritis, and then they could develop arthritis, and then autoimmune cholangitis, pancreatitis, peripheral neuropathies, and central nerve system. And then in addition to these, they could also present with autonomic neurological disorders like orthostatic hypotension and arrhythmias. So these are the pictures of Sjogren's affecting eyes and oral mucosa, where you can see corneal ulcerations, corneal keratocorneal keratoconjunctivitis, and then parotid enlargement in long-term Sjogren's patient, and then the complications due to dry mouth on oral cavity. And this picture shows the characteristic biopsy presentation, where the infiltration is usually the acini of salivary glands are spared, but lymphocyte infiltration, there's abundant lymphocyte infiltration of the gland. So my next case would be a case of polymyositis. She was managed in Kandy by Dr. Tilakamanil Nishanka. She was a 52-year-old lady who presented with proximal muscle weakness and had a CPK of more than 7,000 at the time of diagnosis. And she was diagnosed as polymyositis and commenced on steroids and methotrexate. And it was well controlled for 1 year duration. All of a sudden, she started to flare and CPK started to rise. And then despite high dose steroids and adding up multiple DMARDs, the CPK was remain high constantly. So then Madam has done a CT cap and it was normal. But then I think it was over a course of 1 year, the patient, we have to constantly inquire about malignancy symptoms. So over the course of 1 year, then all of a sudden patient was complaining of pruritus of vulva. That was the only new symptom patient had. And then further, in examining the patient had a vulval mass, so a nodule basically. And then she was reported to gynae oncosurgery, and then they diagnosed vulval cancer. So patient had surgery on urgent basis in a couple of months' time, and then CPK returned to normal levels after the surgery. So what is polymyositis and dermatomyositis? So these diseases come under the broad term of idiopathic inflammatory myopathies. So here I'm only going to talk about dermatomyositis and polymyositis. So both diseases can present with proximal symmetric proximal muscle weakness with elevated CPK. So what are the main differences is dermatomyositis, they have characteristic skin manifestation, which is absent in polymyositis. So usually the dermatomyositis is the one that is associated with malignancies. Like 15% of the dermatomyositis, adult dermatomyositis, could develop malignancy at one point in their course of a disease. Polymyositis is association with malignancy is rare, unlike dermatomyositis. And these diseases, they can present alone or they could even present with other connective tissue diseases like SLE, rheumatoid arthritis, systemic sclerosis, MCTD. So these are the characteristic rash you see in dermatomyositis, where you can see Gauthram's papules on extensor surfaces of fingers, and then heliotrope rash on around eyes. And then the muscle involvement is seen on this picture, the characteristic proximal muscle involvement. So again, the rash could even present in extensor surfaces of the limbs. And then you can see the characteristic shawl sign on anterior chest and posterior chest. And here too, we can see the patient could have calcinosis cutis, which could even be very destructive and extensive. So the X-ray shows calcinosis cutis. So out of this, there is a particular syndrome called antisynthetase syndrome, which is a famous MCQ as well. So when you have autoantibodies directed against amino acyl tRNA, RNA synthetases, called tRNA synthetases, where the patient has characteristic manifestation of interstitial lung disease, non-erosive arthritis, myositis, Raynaud's phenomenon, and then unexplained fever and or mechanics hands. So the picture shows mechanics hands, where you can get splitting of fingertips and the sides of your fingers. So here the characteristic antibody is anti-Jo1 antibody is present in this syndrome. So that concludes polymyositis. Now we'll move on to overlap syndrome. So what is overlap syndrome? So let me start with the case. So this is one of my patients who is currently in my ward. So this is a 22-year-old young lady who was diagnosed with diffuse type systemic sclerosis complicated with interstitial lung disease. Her disease was under control with MMF, HCQ, and a very low dose prednisolone. But in December, she complained of progressive weakness of quadriceps, and there was obvious muscle weakness prominent on left side compared to right. So we suspected polymyositis, and the patient was admitted to ward, and immediately we commenced, gave her IV methylprednisolone pulses, which controlled her symptoms. And then CPK was more than 4,000. So we proceeded with a muscle biopsy, and that showed inflammatory myopathy, likely to be polymyositis. And then we commenced her on azathioprine in addition to what she was already on, and some oral steroids, and the symptoms were controlled with oral this treatment. CPK dropped down to 900 within a month. So what are overlap syndrome? So usually, when patient comes with one rheumatological disease, that's easy to diagnose. But then when patient comes with symptoms and features of more than one rheumatological disease, but then you can diagnose them differently, like rheumatoid arthritis, SLE, you can they meet the classification for more than one rheumatological disease, which could occur at the same time or at different point of time in the same patient. So this comprises about 25% of connective tissue patients. Usually conditions like SLE, systemic sclerosis, polymyositis or dermatomyositis, rheumatoid arthritis with Sjogren's plus or minus antiphospholipid syndrome could overlap. So it's like this. It's like these diseases can interchange. Like SLE can overlap with systemic sclerosis can overlap with polymyositis, RA can overlap with SLE. It's like that. So this could evolve at the same time, or it could come at any point during the course of their disease. Okay. So, but now they have this. Now, this is not like having antibodies against RA, like antibodies against SLE. It's not like that. Now they have detected that there are specific different sets of antibodies that is causing these kind of manifestations. I mean, two different manifestations for, two different kind of diseases. So that is overlap. So there is a confusion about like overlap, mixed connective tissue disease, and then undifferentiated connective tissue disease. So what is mixed connective tissue disease? So it's a different entity. It's not the overlap, it's a different entity. So this patient I met during my overseas training in UK. So he was a 37-year-old Caucasian male, and who has had Raynaud's phenomenon for many years. So initially it was suspected to be primary Raynaud's, secondary Raynaud's due to vibratory tools. He was handling a lot of vibratory tools at work. So he was stable for many years and was not, I think he was on nifedipine. Later on, he started to notice fatigue, shortness of breath, and he had erectile dysfunction. So when he presented to GP, GP has detected elevated inflammatory markers, and then he has proceeded to do antibodies where the antibody, the ANA was positive in high titers. So then he was referred to rheumatology. On examination, he had a very subtle, thickening of skin on his fingers, like mild sclerodactyly. And then when we did anti-U1 RNP, it was positive. And then the 2D-F4 revealed pulmonary hypertension. Then he was diagnosed as mixed connective tissue disease and commenced on immunosuppressives and other vasodilators. So what is mixed connective tissue disease? So to make it easy, I have used this mnemonic, Ramsol, but there are features beyond this mnemonic, but then I just make it brief. So the patient could have Raynaud's phenomenon, atherosclerosis, myositis, synovitis, edema and esophageal edema of extremities and esophageal dysmotility, lungs, lung fibrosis and pulmonary hypertension, and the patient should have anti-U1 RNP antibodies positivity. So when patient has 3 or more features with anti-U1 RNP antibodies, they are diagnosed as mixed connective tissue disease. So it's a different entity form overlap syndrome. So what is undifferentiated connective tissue disease? So when you see a patient and you could not diagnose a particular rheumatological disease, but the patient has some mixed picture. So then you follow up the patient because all these diseases are evolving. So you follow them up for 3 years. Still the patient is not meeting any particular criteria for any particular disease like SLE, MCTD or systemic sclerosis, etc. So then you label the patient as undifferentiated connective tissue disease. So usually if the patient is if the duration is less than 3 years and if the patient is not evolving into any particular type, the patient could be like early, you can label as early undifferentiated connective tissue disease, but you have to be very vigilant. You have to monitor the patient for development of other rheumatological disease. So here the patient should have positive ANA on 2 different occasions. So then only you can label as undifferentiated connective tissue disease because these symptoms can present even in a lot of other medical conditions. So this is undifferentiated CTD. So that concludes my lecture. So what take-home message is, so why do you need to know about these things? So you need to stay vigilant for these symptoms and signs. And when you come across patients coming with these kind of symptoms, or sometimes the symptoms could be very bizarre. So sometimes there could be only elevated inflammatory markers with some fatigability, or there could be different symptoms. So when you come across, please do not hesitate, refer as soon as possible. So that's the take-home message. Thank you. I would like to thank Clinical Society of Matale and our college for giving me this wonderful opportunity.
Thank you very much for the presentation. Any questions from the audience?
I hope that I didn't confuse you all.
Then, thank you very much for that. This is Dr. Also moving forward to our last session on physical health. For that, I would like to invite Dr. Amal Perugaratna to start your physical health. This is your current consultant in rheumatology and rehabilitation and he's a very active member of the college of the council of our college. So he's going to start cases on Amal, should I invite
no, it's all right. We don't have anything in common. Yeah. Only thing is, yes. Okay. Okay. Yeah. Thank you very much, Chairperson, Madam and Sir. Now, basically, we are running a little late. I know that I stand between, I and Dr. Kulisinghe stand between you all and lunch. So I'll try to finish it off early. So I'll be discussing two case scenarios here, common case or rather common symptoms, but which give rise to different diagnoses. So the first case that I'm going to discuss, this patient, in fact, came to me about 3 or 4 months back. So he's a 56-year-old male presenting with multiple joint pains, affecting small joints of hands as well as feet for 10 years. His previous records were not available to me, but the patient claimed that he was on MTX and but treated for a seronegative rheumatoid. Defaulted the follow-up since he hadn't had much relief, was on over-the-counter NSAIDs, which gave him a good relief. He recently had a flare, and therefore he had visited the pharmacist, who had advised him to meet a doctor again. And by the time I see, he had a background history of CKD stage 4, prostate CR on treatment, and also a diabetes. On examination, there was symmetrical empty metatarsobophalangeal joint and metacarpophalangeal joint synovitis, and there was soft tissue nodular swelling noted over the right first MTPJ and outer swall. He had no skin psoriasis or nail changes. I'm sorry about the quality of these two pictures because this patient is so dark, I couldn't grab it clearly. So here there's a nodular area with a yellowish material inside, and also there was a foot lesion in the outer part of the sole, which might mimic an abscess. So investigations why ESR was 92, CRP 48, WBC slightly raised, RF negative, and uric acid was normal. So I'm sorry, I don't have QR code scanning here. So anybody is free to answer. What is the most likely diagnosis? Out of these 5, psoriatic arthritis, seronegative rheumatoid arthritis, polyarticular gout, generalized OA, peripheral spondyloarthritis. Anybody? Give me a couple of answers, please. Gout, okay. Rheumatoid, any other choice? Right. So majority go for gout. So this is his X-ray. Anything that you would see? What do you see in the X-rays? Are there periarticulations or juxtaarticulations? So if you go back to that, so obviously patient has juxtaarticulations. So difference between a periarticulation is, so if you all go through this, so this is where what you mean by juxtaarticular. These are marginal erosions or periarticular ones. And here in these cases, you would see that it's not the marginal, it's mainly juxtaarticular region. It's not over the synovium, or it's outside the synovium attachment. So the second thing is the lesions that we see, are they really gouty tophi? So if we look at to differentiate that, so gouty tophi usually occurs in earlobes, extensor surfaces, and they have a vascularity noted over the lesions. I'm sorry, in that picture, I couldn't grab that because of the skin color, and it was more like gouty tophi than a rheumatoid nodule. So this is a typical rheumatoid nodule where they are firm, And whereas in gouty tophi, what you find inside the chalk-like material. So this is a typical rheumatoid. You would see anybody who can give the diagnosis here. What has happened here? So this is a thumb drop or extensor tendon rupture in a rheumatoid patient. For a registrar, it's a good spot. So briefly, I'll talk on gout and management, and it's also known as the king's disease or ancient Greek foot rubber. Surprisingly, it is the most commonest cause of inflammatory arthritis worldwide, not the rheumatoid arthritis or something else. UK prevalence is about 2.49% in 2012, and unfortunately, we don't have data for Asians. Sustained hyperuricemia is the single most important risk factor. Gouty arthritis as well as the tophi are associated with chronic disability. And the problem with gout is management-wise, it's associated with comorbidities like obesity, dyslipidemia, diabetes, chronic renal failure, and you name anything, and there are associations. So generally for the management, we look at 3 guidelines: 2016 EULA guideline, 2017 BSR guidelines, and also 2021 APLA guidelines, where Chiranti was a co-author. And managing gout, you can consider managing acute flares, long-term management, and the third thing that you need to consider is what is the target of serum uric acid level. So going back to our case, in that patient, the serum uric acid was normal. Was it a wrong lab report or anything else? Anybody to give a good answer for me? Can that happen? Yes. So what happens is, in acute flare, the serum uric acids go and deposit in the blood or the joint. So therefore, there would be a dip in the serum uric acid level. And if you do a serum uric acid assessment at that point, it may not be normal or low. Whereas if you do it 2 weeks later, that would be back to normal, and you might misinterpret it as a normal serum uric acid level. So back in the back to management of acute flares. The important thing is to treat as early as possible, and particularly in Western countries, the patients are well educated on self-medication at first warning symptoms. I don't know, here also the patient might be self-medicating, going to the pharmacy and getting the medications. If already on urate lowering therapy, we should not discontinue, continue with the same dose of allopurinol. Affected joints should be rested, elevated, and exposed in cold environment. Generally, the guidelines gives colchicine as the first option in treating. So you start off with loading dose of 1 milligram, and 1 hour later give 0.5 milligram and continue with 0.5 or escalate if necessary. The other choice is to add NSH with PPI cover, plus or minus PPI cover. Then invariably you can start on oral corticosteroids, about 30 to 35 milligrams per day or equivalent prednisolone dose. That was actually meant. In our patients, you might not need this much of a dose. We generally manage with 10 milligrams of prednisolone or equivalent dose. Articular aspirations and intra-articular corticosteroids are useful in monoarticular flares, and in patients with frequent flares and contraindications to colchicine, NSAIDs, and corticosteroids, you can use IL-1 blockers, which is not available in Sri Lanka. IL-1 blocker is the anakinra or canakinumab. And this is another newer treatment. ACTH, use of ACTH in acute gout, treatment was highly efficacious with a response rate of 78% to 100%. If we look at the mechanism, we might think the mechanism of ACTH is to activate HPO pathway and increase the steroids. But it's not the only mechanism. ACTH is able to stimulate melanocorticoreceptors on macrophages and downregulate the gout inflammation. So the next question is when to start on uric acid lowering therapy. Generally, when we were registrars or medical students, what we used to say is, not in the first presentation, we would look for if somebody has more than 2 flares per year, gouty arthropathy and urate arthropathy or in renal stones. But now the things have changed. You have to have consider them on individualized basis and consider early ULT commencement in some instances, particularly in patient presenting with a young age, very high serum uric acid levels, or in the presence of comorbidity. Even a single attack warrants the commencement of uric acid lowering therapy. So the second question is, what is the target you are aiming at? Generally, EULA guidelines would recommend less than 6 milligrams per deciliter. And in BSR guidelines, you have a less, more stringent control, meaning that target is to less than 5 in BSR guidelines. And once it is controlled, they would try go for a less stringent one, that is 6 milligrams per deciliter. So when to initiate initiating uric acid lowering therapy, you start off with allopurinol 100 milligram and then slowly escalate. If allopurinol, if you don't achieve target uric acid level with allopurinol doses, you might try febuxostat or change over to uricosuric agent or to the combination of them. These are uricosuric agents available. And we also need to reconsider the requirement of diuretics, whether to go for loop diuretic or thiazides, and antihypertensive medicines. Consider losartan and calcium channel blockers, and also statins and fibrates as a uricosuric effect. And lifestyle modification and other risk factors are an important part of gout management. Avoidance of alcohol, sugar sweetened drinks, and also seafood and red meat intake. And unfortunately, if you go through the list, they would be left without anything. So the other important thing is impact of lifestyle modification and dietary modification, drinking plenty of water. So there are special circumstances that we need to consider. Managing gout in renal impairment. In acute attacks, in renal impairment, NSAIDs are contraindicated. Even if you use the colchicine, may need a dose reduction. If you start on allopurinol, starting allopurinol should be done at a lower dose and maintenance dose should be reduced because it increases the risk of allopurinol hypersensitivity syndrome. Wherever possible, use intra-articular steroids or short courses steroids if multiple joints are affected. So this is a guidance on use of EGFR and allopurinol starting doses. If you see, if the EGFR less than 5, you can still use allopurinol with a dose of 50 milligram per week, not the usual doses. And then the maintenance doses, according to the renal handbook, if the EGFR is 20 to 50, the maximum would be 230 daily, 100 to 300. If it is 10 to 20, 100 to 200 daily, and less than 10, it's 100 milligram daily or on alternative days, that is roughly 50 milligrams per day. Closed renal functioning monitoring should be the target serum acid, uric acid achievement may not be realistic despite all these effects. So take home message is gout can be polyarticular and presents as a symmetrical inflammatory arthritis mimicking rheumatoid arthritis. Uric acid levels can be normal during an acute attack. Tophi can sometimes misdiagnose as rheumatoid nodules. So there's a famous idiom to say, when you hear hoof beats, think of horses, not the seagrass. But at the same time, it says anything was possible when you hear hooves, you look for horses, but don't ignore the seagrass. So obviously the common things common. You think about rheumatoid first in symmetrical polyarthritis, but don't ignore the other uncommon causes because you might miss an important diagnosis. The second case that I am going to discuss is on a 36-year-old male presenting with non-inflammatory knee pain, gradually increased over the last 2 years. So he basically came to me and said, so he came up with the diagnosis, sir, I have osteoarthritis. Could you please let me know whether I am having rheumatoid as well? So that of course sometimes irritates us, but I just wanted him to describe his knee pain. And what he described was, knee pain described is felt underneath the kneecap with a grinding feeling when the knee is flexed. Symptoms tend to worse with deep knee bends, going downstairs, running down hills, standing up after sitting for a while. So this patient was had done some surveys, and he has taken glucosamine for nearly 2 years by himself, and he had gone to a lab and got a rheumatoid factor of 6. So that's why he came back to me. So he was worried whether he has misdiagnosed himself and was treating for osteoarthritis. So ESR was 12, CRP was 6. Examination was for me unremarkable with a good range of movement, and the joint lines were non-tender, and the knee was not hypermobile or high. There was no hyperextension, and there was no bursal tenderness. So this was his X-ray. Any comments on this? Is it a normal X-ray or not? Some might call it a little bit of a tibial osteophyte, but you might disregard that. Joint spaces are all right. There's nice margins around. And patellofemoral compartment is also more or less. So at this point, is it osteoarthritis, rheumatoid, something else? What are your guesses? What would you consider? Or am I wrong? Is it osteo? Any? So can it be osteoarthritis? 36-year-old male, yes. Rheumatoid? Unlikely. There was no inflammatory symptoms, despite having a low rheumatoid factor titer. And is it something else? Okay. So if we go back to the history, the description of the pain, what is it? Knee pain described is felt underneath the kneecap. So do you want any other investigation that you would, rather than just X-ray and rheumatoid factor? Any other X-ray views that you would look at? Yes, somebody said? Yes. Ultrasound or CT, would it be useful? So this is his skyline X-ray. What has happened here? So obviously the patella maltracts here. It has gone to the lateral side. and it's touching on the lateral condyle. So this is a case of patellofemoral pain syndrome, which is quite common than we think of. So it is also known as anterior knee pain syndrome, and it's related to, in sometimes overuse seen in runners as patellar tendinitis, or there's a condition called chondromalacia patella, where the undersurface cartilage of the undersurface of patella breaks down and causes the patellofemoral syndrome. And what commonly you see is the patellar malalignment. So patellar malalignment can be related to muscle imbalances, raised Q angle, and flat foot. So what do you mean by a patellar malalignment is, if you have the patella here, it's been anchored with certain vastus lateralis, vastus medialis muscle. Here patella goes to the lateral side because of the imbalance between the vastus lateralis muscle and the medialis muscle. Or it may be due to the weakness of the medialis or increased action of the lateralis. And this is what you mean by the Q angle. Q angle is the angle between the quadriceps muscle and this line drawn from tibial tuberosity to the mid of the patella. And if this increases more than 20, there's a high chance of patella displacing to the lateral side and causing a tracking on the femoral surface. So this is seen in particularly in females who has a wide Q angle because of their widened pelvis. So Q angles in them increases, and there is a risk of patellar malalignment in them. And not to forget the flat foot and pronation of the foot can also put extra pressure on patellofemoral joint, leading to dysfunction and causing a patellofemoral syndrome. So actually, we might need to think about, particularly in young patients who are coming with non-inflammatory knee pains, about patellofemoral syndrome. So the treating patellofemoral syndrome, it's basically lifestyle modification, NSAIDs for pain. Therapy plays an important role. It's not only the usual quadriceps. You need to go in with vastus medialis strengthening exercises, taping and banding to correct the patella. And also, as I mentioned, all these problems might be because of the flat foot. You might need to correct the flat foot with arches. In some instances, surgical interventions may be useful to release the patella to the right place. So why you need to treat this is, in later on, you might develop patellofemoral osteoarthritis if this is not being treated. So back to zebras. Zebras are not the only animal with stripes. You might occasionally need to think about lemurs and also sometimes the ferocious tigers. Similarly, osteoarthritis and rheumatoid arthritis are not the only cause of knee pain. Think about you might need to think about other causes as well, which might be dreadful if you don't diagnose it early. Thank you very much. Any questions, please?
Any questions? Right, shall we thank Patama for an interesting presentation. Thank you very much. Next, I'd like to call upon Dr. Isabella to deliver her case.
When I get to open. Good afternoon. Let's move on to the presentation proper because we are behind the time. I'm going to tell you about two patients with pain in the arm. You must be wondering why I have selected such a simple topic in this gathering. Yes, it is simple symptom, but you need painstaking evaluation to come into a diagnosis and proper management. As I said, it's a common and simple symptom, but it can be a presentation of systemic disease like ischemic heart disease or any other apical lung problem or musculoskeletal problem. It's not only musculoskeletal problem when it comes to arm pain. I want to emphasize how important to get a good history and do a thorough examination in this kind of patient. These two patients who were referred to me whenever they were not responding to normal medication, simple medication given. So if you want to effectively manage these patients, you need to know the underlying cause. My case number one, she's a 36-year-old female presented with pain in the mid-arm. She was pointing to the mid-arm as it has been there for 2 months duration and progressively worsening type of pain, no radiation. She had severe restriction in activities of daily living due to this pain. She being a teacher, it was very difficult for her to wear her sari jacket because of this pain, and her sleep was affected. She had no history of trauma to the arm or the shoulder. Recently, she was diagnosed as having diabetes. So what are the things crossing your mind? Before moving on to examination, there are a few possibilities, but keeping those in mind, we'll move on to examination. Because she was pointing to the mid-arm, I went ahead with examination of her arm. There was no warmth, tenderness, or redness, no features of inflammation, no bleeding. There was no abnormality detected. So we went ahead with examination of shoulders. Her left shoulder was normal, but her right shoulder examination revealed flexion and extension, flexion and external rotation were normal, right? and extension and internal rotation were painful and restricted. And abduction also restricted due to pain mainly. The important thing here is her active movements were restricted, but her passive movements, when I tried to do those things, those were not restricted, but there was pain. So there are two possibilities mainly, rotator cuff tendinitis and adhesive capsulitis. But we'll see what adhesive capsulitis and how they present. In adhesive capsulitis, their external rotation is the first thing to go. They can only do less than 30-degree external rotation. The patients with frozen shoulder or adhesive capsulitis, range of movement reduction is there in two other planes. More than the external rotation, there can be two other planes. You have to have two other plane restriction to diagnose as frozen shoulder. In this case, frozen shoulder, both active and passive movements are restricted. The patient voluntarily, they won't be able to do that due to restriction, and the examiner also cannot do that due to restriction. Right? So our patient, my patient whom I presented, she had active movement restriction, but almost normal passive movement in right shoulder joint. So possibility of rotator cuff tendinitis. There are four muscles forming the rotator cuff: supraspinatus, infraspinatus, subscapularis, teres minor. So any of these can give rise to rotator cuff tendinitis. But here, of course, on examination, the most likely possibility was supraspinatus tendinitis. I'll tell how you check for supraspinatus tendinitis and confirm on examination. That is empty can sign. You ask the patient to abduct the arm, thumb facing downwards, and move forward 30 degrees from the coronal plane. And you try to move the arm downwards and ask the patient to resist that. If the patient develops pain, they get supraspinatus impingement and tenderness. So it is most likely supraspinatus tendinitis. So my patient, the empty can sign was positive. You call it empty can, you are as if you are emptying a beer can. So the green color muscle is the supraspinatus muscle arising in the supraspinatus fossa, running underneath the acromioclavicular joint and get attached to the humerus. So when it runs underneath the acromioclavicular joint, it can get impinged between humerus and the acromion when they move upwards. So you need not to do ultrasound scan for these patients if you can clinically diagnose. If you are in a real doubt, if you cannot diagnose that, or if you are thinking that there's a trauma or rupture of the tendon, go ahead with ultrasound scan. Don't refer all the suspected supraspinatus tendinitis patients for ultrasound scan, because this is not needed if you can clinically diagnose that. Right? This is the right one is the normal. You can see a nicely arranged fibers in the tendon. On the left side, there's inflammation around the tendon. There's fluid. Management of these patients. Number one, physiotherapy should be started in this patient. In physiotherapy, you do two things: mobilization of scar tissue and prevention of further impingement repeated impingement in future. To mobilization of scar, you have to approach the tendon, but in this posture, you cannot approach the tendon because it is underneath the bone. So you move the limb this way across the back, and then you can feel the tendon between the glenoid and the acromion. Then you move the tendon to and fro and release the scar tissue. Prevention of repeated impingement to increase the space between the acromion and the glenoid. You do different maneuvers. Physiotherapists know that. You should give a correct diagnosis for them to start physiotherapy. That is your duty. And in addition to physiotherapy, you can start them with pain relieving medication, paracetamol. There's a pain ladder treatment in WHO. You should start with lower down and go ahead, not starting from upper higher point with tramadol and going down. You should start from paracetamol and go up, as Tiranti said. So you can combine paracetamol and NSAIDs. Please don't combine two NSAIDs together, because it can give rise to bad effects, organ damage. You can give steroid injections if those physiotherapy and other NSAIDs like things are not working. Then other than that, you should manage other comorbidities like diabetes-like conditions which these patients are having, because these things are common in patients who are having diabetes, hypertension-like comorbidities. Back to my case, she improved with physiotherapy and NSAIDs, but when we stopped the drug, the pain recurred. So we went ahead with ultrasound scan of shoulder joint. There was fluid around the supraspinatus tendon. So we gave a steroid injection, and we started physiotherapy after 5 days of injection, and she improved markedly. Physiotherapy continued for 6 weeks. After the injection, you don't start physiotherapy soon after the injection, because the drug should be there around the inflamed sites. If you do physiotherapy soon after, that will squeeze the drug away from the inflamed site. Okay. Let's move on to the patient number 2. Again, pain in the arm. Patient, 28-year-old female, pain down the left arm. This time, younger patient, pain down the left arm. This patient was referred to me because she had undergone simple medication with paracetamol and NSAID-like things, but she was not improving. So she was referred to rheumatology clinic. She is a left-handed girl. Being a left-handed girl, she complained of pain in the left arm while working. She was, especially when she was using a pair of scissors like. And on further questioning, she had, in addition to this arm pain, she had pain in the neck as well for 5 months duration, mainly in the anterior neck. These days we get a lot of neck pains in young crowd because of overuse of this phone and computer. But this is odd. This is anterior neck pain. And she had a history of fever, lethargy, and ill health for the last 6 months duration. Prior to the onset of this pain also, she had this. Because this was an odd case, we went ahead with further examination. She was a averagely built patient, and she had tenderness in the anterior neck, mainly over the carotid, left carotid. That is called carotodynia. On auscultation, she had bruit over the left carotid. And her pulse, I tried to feel, I felt 78 beats per minute on right side. Left side, I could not feel. Same with blood pressure. On left side, I could not get the diastolic blood pressure. And on right side, she had wide pulse pressure, 180 by 60. Systolic blood pressure difference in both arms were 70 mercury millimeters in this case. Rest of the clinical evaluation, heart was in dual rhythm. She had a diastolic murmur on the left sternal edge, not the aortic area, aortic regurgitation-like features. Lungs were clear. Abdomen, there were no palpable masses. We went ahead with the auscultation of renal arteries. There were no bruit. No neurological deficit was detected. Now you all know what the case is. We went ahead with basic investigations. ESR 78, it's high. And in full blood count, she had normochromic normocytic anemia, 10.3 hemoglobin with normal MCV and MCHC, feature suggestive of chronic disease induced anemia. Renal functions, liver functions were normal. Then the diagnostic workout, I'm rushing through this because it's getting late. She's a young girl, less than 40 years now. We consider less than 50 years for this condition. And she has pain while using pair of scissors, that is claudication, arm claudication. Absent arterial pulse on left. There's a deficit in difference in systolic blood pressure between two arms. If it is more than 10 mercury millimeters, significant. Bruit over the left common carotid. The diagnosis was made tracheostomitis. So we went ahead with further sophisticated investigations. Our radiology colleagues helped us with carotid artery duplex. They gave thickness of the wall in carotid artery duplex. Very easy for us to follow up these cases because we need the inflammatory to monitor the thickness of the wall in management, because the thickness of the wall increases due to swelling. This is arteritis, inflammation of the artery. So they get inflammation of the vessel wall, and then the vessel wall thickness increases. Once it gets thickened, we can reverse that with anti-inflammatory treatment. But once it gets dilated, already the damage has been done. So you cannot reverse that. So this is very important to get the wall thickness in this sort of arteritis. They have seen thickening of the left common carotid artery wall, and 2D echocardiogram revealed aortic regurgitation, dilated aortic root. CT angiogram from base of the skull to pelvis revealed dilated root and arch of the aorta with branches affecting. Multiple narrowing in left bronchial artery, left brachial artery and left common carotid artery. No involvement of the descending aorta. Renal arteries we have to specially assess because that can be life-threatening. In my patient, that was not affected. Management of this patient, steroids were started. Initial treatment with steroids. After 1 month treatment, we went ahead with duplex scan of the carotid arteries, and the radiologist revealed reversal of wall thickening with steroids, and she was started on methotrexate, and very, very slowly the steroids were tapered. Tracheostomitis is a large vessel vasculitis. It affects females more than males, age less than 50 years. And you can have a difference in pulse and difference in blood pressure in both arms or arms and lower limbs. Those differences can be there. There's high ESR. So in this sort of a case, if you get a neck pain, just don't label it as musculoskeletal pain, because if you palpate right upper limb pulse only, you won't detect that. Please, if you get a young patient with this sort of pain, feel pulse on both sides, check blood pressure on both sides. Please just do a simple ESR. Then you will detect a hazardous disease. But my patient was okay after treatment. Now she got married and having children. These are the take-home messages. Pain down the arm is a common clinical presentation, but you need to have a good diagnosis, solid diagnosis to give an effective treatment and management. Thank you. Very interesting data, but unfortunately we don't have enough time for question and answer. Because please accept the token of application and
I'm going to